Thank you very much for inviting me to speak this morning. I'm really delighted to be opening up your conference, and I really wish you a day of fruitful discussions and planning for the future. I'm going to ask for my slides to be forwarded from your end. So I want to begin this talk by saying the NHS is world leading in implementing genomics. This is a recent report from the National Academies in the US, and it identified many challenges for embedding genomics within healthcare systems, and that's summarised on this slide. But if you look at the quote at the bottom, where it's referring to the NHS, it says, having a National Health Service allows for the uptake of genomics rapidly and at scale. The progress within the UK stems from the efforts of having individuals who have championed genomics, whether at the grassroots levels, so for example across the whole of the East that this Genomic Medicine Service serves, but also in the political or governmental and healthcare system leadership or leaders of the medical community. And I hope that within the infrastructure that we've created for the Genomic Medicine Service in the NHS in England, that we'll continue to be able to drive forward embedding of genomics, but make sure that it's informed by both grassroots and also top-down approaches. If I can go to my next slide, in October of last year, we published the first NHS genomic strategy with a 5-year vision for accelerating genomic medicine into the NHS and using genomics to really drive the 4 Ps of precision and personalised medicine in predicting, preventing and diagnosing disease and targeting treatment, and making sure that that is available across the NHS as part of routine care. And the strategy set out a number of priorities in 4 areas that I'm going to come back to a little bit later on. My next slide sets out that the components of the NHS Genomic Medicine Service can be seen on this slide. At its core, and not shown on this slide, is a genomics unit within NHS England that coordinates, oversees, directs and provides funding and resources, and also performance manages the service. Within the overall service are 3 main components, so 7 genomic laboratory hubs, 7 Genomic Medicine Service alliances, across the England 17 clinical genomic units, and then a partnership with Genomics England to deliver whole genome sequencing and to continue to populate the National Genomic Research Library, as one of our key principles is aligning routine care with research endeavours. A key other element has been aligning with the genomics education programme, but also recognising in terms of the delivery of the service, we're very dependent on other clinical specialties, especially in the cancer space. You can see that these are the areas of our Genomic Medicine Service across the NHS in England. But the principles are driven by patient and public involvement at all levels, a standardised model of contracting, delivery of practice, although we're not there yet, that it's focused on equity of access, it's clinically and scientifically led, and it's responsive to change. And some of these still remain challenges for the service, which I'll come back to. My next slide just sets out that if we look at this in terms of the GMS geographies, I just want to focus on the East. The East has 1 genomic laboratory hub in Cambridge, 2 local genomic laboratories working with the hub lab in Cambridge. That's 1 in Nottingham, 1 in Leicester. 4 alliance partners within the Genomic Medicine Service, 3 clinical genomic services. But interestingly, this just pulls out some of the challenges in terms of embedding. It's working with 13 ICSs, ICBs, 32 provider trusts, and serving a population of 8.4 million in this whole geography that's very dispersed in terms of what it covers. And this just outlines some of the challenges of systematic embedding. If I go to my next slide, this just sets out this is a new approach in general, though, to genomic medicine. It's multi-specialty. And so the GMSAs are key to embedding genomic medicine in the mainstream healthcare and trying to develop the workforce. There's involvement of a broad range of specialties, and it's supported at all levels by the clinical genomic services. There's involvement from all staff groups now across the NHS, from our nurses, our midwives, pharmacists, as well as our scientists, medical specialty staff, and also our allied health professionals. There's cross-professional involvement now in genomic multidisciplinary teams for cancer and rare disease, and in the transformation projects that the GMSAs have been leading. Nationally, expertise is shared across the country, because what brings the Genomic Medicine Service together is that this is a network. It's networked across the East, but East works with the other 6 geographies across the country to share expertise and best practice. Some services are provided nationally within the service, and we have quite extensive international collaborations now on sharing of expertise. My next slide just sets out that we have a multimodal approach to genomic testing. This is set out in the National Genomic Test Directory that sets out the tests that will be funded by the NHS in England, sets out the eligible conditions, the type of technologies that should be applied, and this is across this testing spectrum, from targeted testing to now large gene panels, for example, in cancer, so in somatic cancer genomic testing for both hematological malignancies and solid tumours, and then through to some exome sequencing, which looks at the coding regions of our genes, so that's accounting for about 1% of the whole genome, through to whole genome sequencing that is attributable to about 10% currently of our NHS testing overall. Overall, the NHS delivers just over 700,000 genomic tests each year, and that number's rising. If I go to my next slide, this just sets out, and I'm not going to talk through this in any detail, what this means for cardiology in terms of having a test directory, having an approach like this. So it's having an impact across prevention, personalisation, and in prediction, for example, associated with cardiology. We're moving from more single gene tests to when we have panels for cardiac inherited conditions, and we're constantly looking across the spectrum of cardiovascular diseases in terms of the evidence to support expansion of testing. So we have on the right-hand side, we have some testing, for example, at a single gene sequencing level for Brugada syndrome, small panels for familial hypercholesterolemia, and that can include, for example, some SNP testing that actually starts to move us towards polygenic risk scores. Through to some large panel testing, for example, for some of the pediatric cardiac myopathies or thoracic aortic aneurysm, but then moving into whole genome sequencing for pediatric or syndromic cardiac myopathy, and this will increase. This is the same across all the different specialties. And And I think what's important as you think about how you embed is taking this specialty approach and really making it understandable for the specialties about what's available. If I can go to my next slide, this just sets out that we are, as part of our strategy, is linking both the diagnostic genomic test with the treatment pathway. So with this pathway for more precise and accelerated diagnosis, and that includes being able to access a rapid whole genome sequencing service provided by Exeter for NICU and PICU patients to meet criteria, through selecting accurate and effective treatment, and that could include, for example, through testing for the potential to use NTRK gene fusion inhibitors, to really driving the fact that we have fewer treatment adverse drug reactions, and as example here is for the use, the testing of DPYD for potentially fatal variants in the individual who may receive the fluoropyrimidines, through to moving towards better collection of how we can look at outcome from genomic testing coupled with target and precision interventions in terms of survival and quality of life. And importantly, we're working with partners to have an approach so that we can look towards the future of new medicines that are coming over the horizon, to make sure that our panels reflect those new medicines, particularly in the cancer space, but also linking with the medicines governance and optimisation programme in general, recognising we spend around £17 billion on drugs each year, a large percentage of which don't necessarily have the outcome that we expect. If I move to my next slide, this just indicates one example of when we get this right and what it means for the individual. And the Exeter rapid exome sequencing service in Exeter identified 19-month-old Teddy as having a rare inherited condition called metachromic leukodystrophy. This is a really debilitating condition that usually appears about 12 months after birth, with a life expectancy of just 8 years. Teddy was identified with this condition. At the same time, NHS BT, through the Filton facility, had started to manufacture the gene therapy Limeldi. Teddy received Limeldi, the first patient to receive this gene therapy, is doing really well and is expected to live a full and healthy life. Unlike her sister, who's 8 years of age, not likely to survive, and was unable to have this gene therapy treatment. So when we get this right, there's tremendous benefits for the individual and for the family. If I can go to my next slide, this just sets out that the Genomic Medicine Services have been undertaking a whole range of transformation projects, and that includes in the East. The East have been leading with the South East the 2-year project with the British Heart Foundation in sudden cardiac death, and working with the coronal system to establish a pathway from the index deceased case right through to family members actually accessing inherited cardiac condition clinics, and then undergoing genomic testing, which will include for whole genome sequencing. The East has really been driving our approach in Lynch syndrome, and with appointing MDT Lynch champions across colorectal cancer and gynae MDTs, and in testing, for example, for circulating tumour DNA in non-small cell lung cancer, as well as working to establish monogenic diabetes champions within services, such that overall we've more than doubled the number of monogenic diabetes test requests per month. And I hope today, Richard, that you'll start to think about what else needs to happen to really drive this forward as we go forward. The Lynch Syndrome project will remain as a national programme. If we can go to the next slide, I just really quickly want to tell you our first priority in the genomic strategy is embedding genomics in the NHS through a world-leading service model. You can read the priorities, but we've made great progress in trying to establish integrated governance and networks across that genomic medicine service. Those components of the service, in establishing genomic training academies to start to offer a virtual approach for training, in establishing an NHS GMS people and communities forum, and to run that through the whole of that genomic medicine service, and in national and global collaboration. And NHS England are entering into MOUs with a number of countries across the globe. If I go to my next slide, the next priority is around delivering equitable testing and linking this to precision medicine. You can see and read what our priorities are within the strategy, but we've really established now a mechanism for horizon scanning, as I mentioned on the precision medicine pathway slide, for rapid adoption. Both of understanding the rapid adoption of medicines and the need for genomic testing, but also a mechanism for rapid adoption of technologies. We've been aligning clinical trial targets with standard of care NHS testing, particularly in the cancer area, so that individuals can be identified as eligible for clinical trials, and then through the research coordinators that we will be funding, put in touch with those trials. And we've been evolving the genomic test directory strategy to include focusing on long read sequencing, as well as, for example, RNA sequencing. In my next slide, this sets out our focus for enabling genomics to be at the forefront of data and digital revolution. And this includes how we store and analyse NHS data from multiple genomic analyses and bring that together with other phenotypic data, so that we can properly look at genotype, phenotype correlations and understand what this means for individual patients and their treatment. We're expanding the use of NHS genomic data to support approved research through the research collaborative, but through other endeavours. And then we're developing a genomics implementation plan that will look to improve end-to-end test ordering, sample tracking, better coordination and interoperability, and driving increased efficiencies. And that's just a number of key areas. And then finally, my next slide just sets out the fourth priority within the strategy is evolving the service through research. And we will be establishing NHS genomic networks of excellence to work with life sciences and other partners to really rapidly develop the evidence and model of adoption for the NHS. And these networks of excellence will be funded for the first 2 years to provide that evidence and that model. We will also nationally be working with industry to signal the needs of the NHS GMS in a new industry partnership, and we'll be evolving the NHS Genomic Medicine Service Research Collaborative that enables researchers to bring projects through that research collaborative for consideration for accessing the NHS Genomic Medicine Service that's been infrastructure that's been funded. But this enables more research to be delivered at scale and speed, and to evolve the whole of England in that research. If I can go to my next slide. These are some of the ongoing challenges: how we drive new and sustainable models of care with genomics within it, how we develop the multi-professional workforce, especially when some might only access genomics as a part of that pathway, how we reduce variation in access and waiting times and backlogs, how we embed genomics across all specialties and make that understandable for those specialties, how we systematically adopt new technology, and also working practices to drive efficiencies, and then some of the ethical considerations. And we are nationally establishing an equality, ethics and legal board that will provide a more national oversight of all of these issues and provide, for example, advice to our 7 geographies. And I've mentioned some of the lack of IT connectivity and standards and how we better use data for insights, particularly at a population health level. If I can go to my next slide, this just says if we get it right, then we do and make a real difference for patients, including baby Oliver from the east of England, where whole genome sequencing was able to determine the mass that was seen on his leg when he was born was actually a benign tumour rather than what was expected to be an infantile fibrosarcoma, really sparing that family from having to go through the process that had been set up for chemotherapy and sort of quite extensive surgery. So when we get it right, it actually means that we get it right for the families and for the patients that we actually serve. If I can finish then on my last slide, which is a quote from Amanda Pritchard, just to set you off for today, in relation to the NHS strategy. And she said, in many ways, this is one of the most exciting bets the NHS is making. So I say to you all today, to what Amanda said in October last year, you've got an important job to do, and we're expecting big things from the East. And you've got the backing from the national team, from your regional teams, and from the team that lead the Genomic Medicine Service in the East.
Okay, so first question, what comes to mind when you hear genomic genetic testing? So that's producing a word cloud for us. And I think you can see probably a lot of what we would expect there, which is fantastic. And sitting in the middle is diagnosis, and I'm sure that's relevant to a lot of people here. But looking at some of the other comments there, it's moving a bit too quickly for my slightly elderly eyes. But there are clearly lots of other issues there, and we will, of course, endeavour to share all of this. I've spotted one, complicated. It is. Challenging, it most certainly is, but that's one of the reasons why we're here today in terms of, as Sue says, in terms of how we take this forward to the benefit of everybody. Right, next question. How would you rate your confidence in terms of the following? Wow, that's live. Okay. Keep going, any more answers? So I think that's really, really very helpful. I think clearly a lot of people here have got experience in genomics. That's possibly why you're here. Some people less so, but very, very clearly across a broad range of areas, there's still a lot for us to do. And when we start looking at the more technical aspects in terms of interpreting test results, clearly these are areas that I think we were well aware of, that we knew we were going to have to work hard on. But across all of those domains, I'm delighted to see actually that, you know, we're certainly halfway and beyond, which I think is a great testament to how the GMS is working today. So across patient consent, taking family histories, making referrals, still very, very critical in this particular time, and requesting testing. Okay, thank you very much indeed. I think that's really sort of set set things for today. Let's just keep going with slides. So I had a couple of placeholder slides, just because some people here may not be completely aware of what the GMS is all about and what the GMSA is all about, but I think Sue has very clearly described that, so I'm not going to dwell on that, but you can take away the key themes around embedding genomics into the NHS and delivering equitable testing. And in terms of the East GMSA, you can see in red we are one of the 7 Genomic Medicine Service alliances, which is delivering that particular model that Sue described. So we're very much part of the wider GMS, but as I said, facilitating delivery and embedding across the NHS. I think it's very important to highlight as well that East Genomics covers, as Sue described it, quite a complex and broad geography. So we've got the east of England and East Midlands. We are not always very natural partners in various different NHS structures, so this has been a big challenge. And you can see the very broad variety of not just laboratories, but also acute trusts, other trusts, community trusts in this region. And this is one very big challenge that we are currently facing, which is why our engagement process and strategy is so key to making sure that no part of our geography really is not engaging with the genomics conversation. We have a very well-developed governance and infrastructure now. I won't go through this in detail, but you can see that looking at this, we have quite a number of working groups, for example, covering nursing, midwifery, medical and rare disease, pharmacy, the clinical services, research and innovation, cancer, hemato-oncology, pathology, informatics and digital and comms, and workforce and training. All of those are feeding into this particular structure, which ultimately at the partnership board level of East Genomics, which again covers all those regions through the principal partners that we've already heard about, and reports into the NHS England Genomics unit. And here are the key people, and they're all here today. Please make every effort to meet them, have those conversations, and we will be doing exactly the same with you. We will be reaching out all through the day. Here are members of the Genomic Laboratory Hub, so again, part of the GMS, and again, they'll be here today. Please engage and meet and discuss any particular issues that you've got. And importantly, we have our patient and participant voice panel here again. You'll again be meeting people today, people who are speaking today, and a very key part of the overall GMS structure. So you can see that we've got a very broad range of individuals contributing to East Genomics. So please make use of our marketplace going forward. You'll see that around the room today. Use it as a point of contact to speak to these groups and as many other people as you possibly can.
Good morning, everybody. It's a great pleasure to be here. And what I'm going to be talking about today is our work in the prostate cancer space. When I think about genomics, I'm always struck by the fact that 1 in 3 jobs for our children at school today have yet to be invented. 1 in 3 jobs. So we're living in a time of great change. And when we look up at the stars at night, we're looking into our past. And that's what genetics is. It's looking back at the 2 billion year history of our genes. I can't believe after 2 billion years, this is what it can come up with. But anyway, so genetics is a study of the past and helps explain the reason why we might have been ill in the past. Now, personalised medicine, what I'll be mainly talking about today, is about trying to predict response to treatments. And that might include microbiology, which we all know about through COVID, but also thinking about tumour genetics, and also thinking about pharmacogenetics, the right drug, the right dose first time. But as we move further forward and we think about crystal ball gazing and predicting in the future, what you really need, apart from just things like SNPs or whole genome sequencing, what we're going to need to work towards is integrated data science, as data and fresh water become the currency of the 21st century. I would argue that rather than just thinking about reason, response, and predicting risk, there is a fourth R to learn here, and that's about relationships. And that's one of the key focus that we've been working on in our partnership with Prostate, with our clinical laboratories, our molecular laboratories, and also with our outreach programs and links with fantastic groups such as Prostate, who are here today with Rob Banner. So we've been looking at prostate cancer partly because we knew on the horizon there would be better treatments. In ovarian cancer, treatment has been revolutionized for people who have inherited alterations in BRCA1 and BRCA2. These are the breast and ovarian cancer susceptibility genes. But we've gone beyond that now, from thinking about inherited gene changes to think about gene changes within tumors, and actually beyond thinking about the genes and actually looking at the impact of genes on the whole genome. I don't know if any of you remember the 1980s. None of the ladies here look old enough to remember that. But what the teenagers used to do is put a tape into the radio and record the 40 most popular tunes on a Sunday evening and press play and record when the song started and then predict when the DJ would come on again and press stop. So, and in 1984, something happened called rap music, and along came Shaka Khan with a repeat sequence, which went something like Shaka Khan, Shaka Khan, Shaka 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 Khan. And so there would be teenagers with 4 repeats, 8 repeats, 12 repeats. So what we would end up with is you could look at the impact in the DNA on the replication of repeat sequences by looking throughout the genome at what is actually happening at these repeat sequences. So that is a marker of genomic instability. So we've gone from a point of thinking about family history to thinking about genes within tumors and family history and inherited changes. Well, now we're looking at the impact of genomic changes. Incredibly exciting, and really delighted that Patrick is here and is going to be talking, I understand, from our genomic laboratory, and the huge progress they've been able to make, not only in looking at those gene changes, but the impact of gene changes on the whole genome. And the reason why that's important is because treatments, which we used to be able to give perhaps to those with those inherited links, maybe 14%, you can actually now, in ovarian cancer, give to up to 50% of patients. So we're moving to a point where we can personalize not just on genes, but on the impact of genes, which is great progress. So here, in our prostate cancer work, what we wanted to do is almost catch up with some of the progress which has taken place in ovarian cancer and partly in breast cancer. So we're trying to build those relationships, and trust is a key aspect. As we start to think about having a conversation about men who are at risk of prostate cancer to come forward, particularly at high risk of aggressive disease at a young age. So how do we get those type of people to come forward, but then what can we offer them? Can we start to offer these genomic tests because we know improved treatments are coming up? And this is really important because so many men are almost dying in silence here, not wanting to talk about prostate cancer. And it's a massive issue because 85% of men over the age of 85 at post-mortem have prostate cancer cells. Well, not everybody with prostate cancer dies because of it. So you've got to find the right patients at the right time. And that's about the predictive nature of genomics. It's not just being able to work out if someone's going to get it, it's working out what that impact's going to have. And that's when you need to integrate data. But you've got to start that debate. You've got to build that trust. And what we wanted to do was look at people with a family history of prostate cancer or breast and ovarian, as we know they can be linked by the genes, but also regarding issues of ethnicity. Because we know that men of African descent are at double the risk, 1 in 4 men. And they're not only at risk of developing prostate cancer, it can be younger and it can be more aggressive. And so many men are dying. And the problem with malignant prostate cancer is that it doesn't always present with symptoms until it's too late, whereas benign disease tends to present with symptoms. So if you're going to catch these tumors early in these highly targeted groups, you've really got to be able to get them before they actually have symptoms. And here you can see the risks and the target groups. But a lot of men do struggle thinking about this because, of course, there's a risk of side effects with treatment of impotence and incontinence. But we need to get to a point where we're having these types of conversations. So what's the best way of actually working out what people want to do? You've got to go out and meet the people on their terms. You need community champions, and you need to go out. So Pamela Campbell-Morris, we started this with her Play Dominoes Talk Prostate Cancer. And I didn't know, but particular members of this community love to meet together to talk about things and to play dominoes together. So we arrange these events, and we go and we do a small talk and start to build those relationships. The video we had with Disparities Group, which Joe Lowry, our project manager and my right hand, helped develop, that's just had 55,000 views on Twitter, I saw this morning. So that's come along really nicely, and that's with Sylvester the cat, one of our local celebrity patients out in Leicester, talking about his experience. And it's really important, not only that you go out to where these people are to start to have these conversations, but you have the message come from the community as well. We've had a number of videos that we've developed with the community to start to raise these messages. And we've also got other champions in other clinical areas as well, some of which I know are here today. So all their work is hugely appreciated. So we've taken a stepwise approach with this. Get the right stakeholders on board. Have your terms of reference. Make sure you've got your peer patient champions. Work closely with passionate people who have got skin in the game, who are there in it for the long term. I always say, their disease, my career, both our lives. So groups like Prostate, groups like Be Me Cancer in Nottingham have been absolutely integral and central to this work. And they have the community links, and they have been incredibly supportive, developing leaflets, arranging events, and helping to build those relationships. We've also worked very closely with our pathologists in Leicester, the clinical genetics department, and with Patrick and Jonathan and the team at the Genomic Laboratory Hub to develop the pathways to be able to do molecular testing of tumours. Prostate cancer is difficult in terms of the tissue, in terms of being able to actually process it, but also you can develop more than one tumour within a prostate, and they can have different genetics. So we've worked with our academic colleagues, and that was talked about earlier, so with Colin Cooper at Norfolk and Norwich, to actually work out how best to process the tumours to be able to get the genomic material we need to be able to do the genetic testing. And we started off by people with the disease, with BRCA1, BRCA2 gene changes, and people that we knew that were negative as controls to check the technology first before we started. What we were able to find in our pilot was that there were some patients where they had this gene change within the tumour, and that's great because new treatments have just been approved within the last month for breast cancer and prostate cancer. So that's fantastic that the personalised medicine drug is now available. And as a result, perhaps, of this work, the criteria for genetic testing has changed. So now any man under 50 with prostate cancer can have a blood test. Any man under 60 with metastatic disease can have a blood test to look at the BRCA gene changes. And in particular examples, we will be able to look at the prostate tumour tissue as well. And that's important because you've got twice as number of gene changes within the tumour. So it's incredibly helpful. This is part of a much broader network of work that we're doing. We want to build these relationships and the trust so that we can look at the wider aspects of genomics. So here we are with Gemma as our lead nurse and Joe Lowry out in the community at football grounds, and we've done events at the Leicester City Football Club. A few weeks ago, Emil Heskey and Steve Walsh were there, and a number of different groups, and it was led by the Lord Mayor, and we're linking in with the West Midlands as well. We've done a video with a lovely chap, Andy, who is a patient where we found the gene change within his tumour. We then found it in his blood, and we've been able to test his family and his story is there and out there. This is linking in also with future research, looking at the impact of PARP inhibitors. These are the targeted therapies for people with these breast, ovarian and prostate cancer susceptibility gene changes. As I said, we're linking in with the West Midlands through the Commonwealth Games legacy. We know a lot of men of African ancestry come from the Commonwealth, and we're linking in because the 100,000 Genome Project was an Olympic legacy, and so we're now linking in with the Commonwealth Games legacy to develop this across the Midlands corridor into Wolverhampton. And we're also linking with Prostate Cancer UK in our national campaign, looking at men living with prostate cancer who've got a low Gleason score, which means tracking the tumour. And we hope that by understanding the genetics within the tumour and the blood and the family history and the PSA score and the MRI, we can work out when to intervene. So it's really exciting. We're also linking into schools, an outreach program. Anybody who wants to have a look at this and understand, for instance, why they may not like Brussels sprouts or their hair's ginger, or what came first, the chicken or the egg, or why they put blue in a traffic light, let me know. We've got the answers to all of those. But the aim of building this trust is that we can go on and help to build patient self-navigation digital tools. That we've got that up and running now for Lynch syndrome, which is a bowel cancer susceptibility with that genetic instability that we talked about through the Shaka Khan test. But from that, we're building pharmacogenetic capacity. I want to see a day where we can go into Boots, other pharmacies are available with a QR code, check your prescription against a pre-ordered saliva test, against your drugs, and against your genetic code, and it will tell you red, amber, green, right drug, right dose. So we've got this, and we've got a demo up and running, and the aim is to be able to use this technology so that for patients with Lynch syndrome, they will be able to get the right chemotherapy based on their genetic profile, but develop that also for statins, but also for the patient to be able to see how other patients with their same genotype got on with that drug. So did they have side effects like myositis or liver problems, and did their cholesterol go down? So that's true participation. So we hope that in the future, within 30 seconds of your prescription, you'll be able to check if it's right for you and what other patients with your genotype, how they got on with that drug as well. That is when we break through with mainstreaming, for me, for genomic medicine, and when we get everybody on board. When we treat disease for what it is, not what it looks like, when we give people the right drug, first dose, first time, and also we screen on risk and not age alone. A huge thanks to all of our clinical team, particularly Maria and Joe and Gemma, but also for Prostate and our GP colleagues as well, Dr. Parwan and the Lord Mayor who helped set this up, but particularly my last thanks to Prostate and all the people who are fighting the good fight. It's a huge honour to be here with you all today and also to introduce my friend and colleague, Dr. Eddie Blair, who I've known for a number of years and is Deputy Chair of the Patient Involvement Group. None of this works unless it's co-created and if we have good dialogue together and build trust in the future. So I'm going to hand over to Ed, and thank you much for your time today. All the very best. Be around for the rest of the day.
I'm going to talk about three things. One is my diagnosis, secondly my treatment, and thirdly genomics, which has played a big role in how well I feel at the moment. Diagnosis was almost accidental. I went to the GP after COVID for a health check and said, you know, while you're doing my blood pressure, which is normal, you've taken blood for lipids, etc., could you do a urine test? And it was full of glucose. So they said, you'll need to come back for an HbA1c. And I said, okay, I'd like to have a PSA test at the same time. And it was, ooh, you're going to have to talk to the GP first. So talk to the GP, goes through the wrist, did the digital rectal examination, said it's mildly swollen prostate. I will do a test for you. And then he phoned me back a couple of days later, and it was 600. Yes, 600 nanograms per mil or micrograms per litre, whatever measure you take, 600. I thought, you've got the decimal point in the wrong place. So they repeated it, and within 2 weeks it had gone above 700. So I got a call I was put in the 2 weeks program and told I was probably had metastatic stage 4 prostate cancer. I said, but I feel fine. Well, we'll do the tests anyway. So bone scans, CT scans came back and again confirmed widespread bone metastases and lymph node involvement. So here's me, like the case Julian was describing, fitting well, playing golf, going to the gym, cycling occasionally, trying to avoid cycling with Dick Sandford because he's quite fast actually. But anyway, that's a different story. And so my first comment is, why isn't there a screening program for this? Right? I know the biopsies are difficult to take, but I've had biopsies taken, and apart from a bit of discomfort in the day and an infection that followed that was treated very quickly, it's actually not that bad. And there's new imaging technologies coming through that can actually help with that as well. So, let's think about screening, and I know that there's a plan to have a screening program in place in a couple of years. So that would be one thing I'd feed back to Sue Hill. Then we go to treatment. So immediately following that diagnosis, I was giving some very short-term hormone deprivation therapies, a thing called bicalutamide, first in class treatment. And that was used as a cover for me then getting a long-acting 3-monthly injection. Now, why I'm telling you this is that towards the end of that 3 months after they've taken me off that cover, we found that the PSA was rising again. So I said to my oncologist, look, this is coming back up again. I think the long-acting isn't as long-acting as it should be. So he said, okay, I'll put you on a second-generation androgen deprivation therapy called enzalutamide. Now, that worked brilliantly. So in the last 5 months since my initial diagnosis, the level of PSA has fallen by 99%. It's gone from that peak of 700 to around about 5 now. And the follow-up bone scan has shown that the density of signal has gone down in existing METs, and there's no new METs. So actually, that treatment has been very, very effective. And I've had really good interaction with my oncologist because I've said, I'd like to do this, I'd like to try that, etc. And he's responded very, very quickly and said, yeah, that's a good idea, or yeah, that's not a great idea. So that one-to-one interaction with my oncologist has been very good. So then the third aspect I'd like to briefly mention is genetics. And it's all back to Julian and Dick again. The PPV panel that I joined in September, we met face-to-face for the first time in September. And at that meeting, I met Gemma Gunn and Joe Lowry and United Against Prostate Cancer. So from talking to them, I got enrolled in the study that Julian mentioned to look at somatic DNA. So the somatic DNA has been looked at, and 16 genes are normal, including BRCA1, BRCA2. Some greatly relieved. But something else was done using a thing called TSO 500, and that spotted a change in a gene called BRAF. So I've got a mutation in BRAF, G469A, which is seen in probably about 1% or so of prostate cancer, so it's relatively rare. But I think that explains why I may have metastatic disease with very few symptoms. So it's been quite an aggressive disease, I guess, but I think it's down to this mutation. Now, what's exciting, again, as Julian says, BRAF is something that's been targeted with some precision medicines, particularly in lung and melanoma, and it has good effect, but it's not that durable. So one of the challenges is getting a durable response with some of these things. And of course, in the literature now, there's cases where they're combining BRAF inhibitors with other small molecule inhibitors in that signaling pathway that BRAF is so instrumental in. So there's a durable response with 2 or more inhibitors. So again, a combination is quite important. But most exciting for me is the fact that some of these studies are beginning to use immunotherapies as well. So although I was told initially that my cancer was incurable, and that's the dogma, the number surviving, as Julian pointed out, is now about 50% over 5 years. That's gone up dramatically in 2 or 3 years from 20% and less. And I think that number will increase because we can start to look at cures with immunotherapies and combination therapies. So I'm putting my hand way, way up to say, yes, I want to be involved in those studies that will combine treatments against BRAF and with immunotherapies to try and cure my cancer. And on that front, again, Julian put me in touch with the Royal Marsden, Professor Eels there, and she has been excellent in getting me involved in some of their studies. I'll be involved in Barcode because I don't qualify for the diagnostic aspects of the work she's doing. So somatic sequencing, absolutely Julian. Targeted treatments, absolutely Julian. Living with cancer, absolutely Julian. I will die with it, but not from it. So thank you for your attention.
Thank you, Emmanuel. So I'm going to be changing gear a little bit and talking about Lynch syndrome. So for those of you who don't know what Lynch syndrome is, it affects an estimated 175,000 people in the UK and is the most common cause of inherited endometrial and colorectal cancer. It leads to 1,100 colorectal cancers a year in the UK and is responsible for 3% of all colorectal and endometrial. Typically, the tumours will show an absence of one or more of 4 proteins that are related to Lynch syndrome, and I'll explain a little bit more about that. But it can also cause multiple other cancers, including gastric, small bowel, urinary tract, biliary tract, and brain, as well as skin, pancreatic, and prostate cancers. It's an autosomal dominant condition, which means that if somebody has the condition, there is a 50% chance that their children will also inherit it. And it can be inherited from either side of the family, so from either mothers or fathers. The condition causes an increased risk of cancer, which actually ranges from 10 to 57% of colorectal cancer and up to 49% risk of endometrial cancer. We talk about Lynch syndrome as one condition, but we actually know now that it's really more like 4 different conditions. The genes are very specific in the cancer risks that they cause. We know that MLH1 causes the highest risk of colorectal cancer at 57% in men and 22% of upper GI cancer in men as well, while MSH2 causes a 24% risk of prostate cancer, which is one of the cancers we didn't originally think was linked to Lynch syndrome. We also know that MSH2 causes significant risks for women with a 49% risk of endometrial and a 17% risk of ovarian, while the genes MSH6 and PMS2 have much lower risks. So although we would say somebody with these genes has Lynch syndrome, the reality is that their risk of cancer is much lower and the implications in terms of screening are much less significant. So in terms of the management for this condition, we would arrange colonoscopies every 2 years for people with Lynch syndrome, starting at either the age of 25 or 35. We also know that treating people with aspirin lowers the risk of cancer by 50%. So if you know someone has Lynch syndrome, you can decrease the risk of cancer very simply by giving them aspirin. We also know that H. pylori is a very significant risk factor for gastric cancer, and again, detecting and treating this can lower the risk by 50%. So another very easy intervention. For women who are unaffected and over the age of 40, they may consider having their womb removed and, depending on the gene, their ovaries, again to remove this risk of cancer. And for men, leading on from the prostate project, we know that they can have prostate screening with PSA testing, or there is a study known as IMPACT looking at the detection of prostate cancer. Leanne, who is coming to speak next, will tell you more about PGD, but this is pre-implantation genetic diagnosis, and it's a type of IVF that is aimed to prevent the next generation from inheriting the condition. So by establishing embryos, you basically extract a woman's eggs, fertilize them with her partner's sperm, and then grow them for a few days, and you can then test these embryos for the gene alteration and then lead to a pregnancy that is unaffected. So this is a very helpful technique for families. The other big thing about Lynch syndrome is it impacts the treatment of cancer. So if somebody has a colorectal cancer that's linked to Lynch syndrome, they would consider a subtotal colectomy rather than a segmental resection. And that's because the risk of another primary is high enough to consider more extensive surgery. Obviously, that's not an easy decision, but it's something that the patient and the surgeon would discuss together. We also know, as other speakers have talked about, the impact of medication targeted based on inherited factors. So immunotherapy is incredibly helpful for both endometrial and colorectal cancer, and it has been shown to be effective in between 46 to 100% of metastatic endometrial cancers. So these are patients that have metastatic cancer that have very limited other options, and immunotherapy has shown that it can put them in remission up to 100% of the time. So that is incredibly significant for families. We know that 1 in 350 people have Lynch syndrome, but 95% of people don't know they have the condition. So I've just shown you the management and the impact of knowing someone has Lynch syndrome. We can reduce their risk of cancer by 50%. We can target their treatment very significantly and prolong their life even when they're affected with cancer. But if they don't know they've got Lynch syndrome, we can't do any of these things. We also know that even when people have Lynch syndrome, historically they haven't always had the management they should have had. So the project that we're working on is aiming to change all of that. And it lines up very nicely with the NHS long-term plans, which is to identify all cancer, well, 75% ideally, of cancers at stage 1 to 2 as soon as possible, but certainly by 2028. The way that we do that is by testing every endometrial and colorectal tumour for Lynch syndrome. So that's done predominantly by immunohistochemistry, but also by microsatellite instability. Essentially, anybody diagnosed with colorectal or endometrial cancer is now screened for Lynch syndrome. But that wasn't the case, and that's why we've had a 2-year project to try and implement this. So once people have had this testing, if they have proficient mismatch repair, that means they probably don't have Lynch syndrome. In genetics, we don't give absolutes. It's always most likely, probably, the risk is. So if somebody has proficient, it's less likely. If someone has deficient mismatch repair, then there are a couple of reasons that can happen. 15% of colorectal cancer and up to 30% of endometrial cancer show this anyway. So sometimes we have to do further tests to differentiate whether it's real Lynch syndrome or it's something that's happened by chance. But the bottom line is, we get to a point where germline testing is indicated. So if somebody needs germline testing because they've got cancer and they've been screened for Lynch syndrome, we want to test them as soon as possible. So this should happen at MDT, as soon as the MDT knows that this is a possibility. There are different patterns on immunohistochemistry. If you see absence of MSH2 and 6, it's more likely to be inherited. But if it's MLH1, you need to do further testing, which is methylation. The important points to know, at this point, a family history questionnaire is not mandatory. So we're basing all further testing on our screening. It is helpful to know whether people have cancer in the family, but it's not necessary. We certainly don't want to delay the further testing. And we have patient leaflets available for this cohort of people, so the ones that have been screened and may or may not have Lynch syndrome. This is just summarising the pathway, which is essentially everybody's tested, every tumour is tested for Lynch syndrome. Depending on the pattern, they may be offered germline testing, and they should be discussed at MDM, multidisciplinary team meetings. When germline testing is offered, historically it's been done in genetic centres, in our genetic services, we've got quite a backlog of patients. It takes a long time for people to be seen in genetics, and we really don't want barriers between people and genetic testing and the ability to implement better management. So there's now this massive push for mainstreaming, which I'm sure you'll hear a lot about today. Mainstreaming is when genetic testing, genetic services aren't really the gatekeepers anymore. So the testing is done by the MDTs, by oncologists, surgeons, or CNSs. So it's done right at the point of diagnosis, and more people have access to testing. Once we have identified a Lynch carrier, they are then referred to our new system known as Lynch Syndrome Expert Hubs, which is another project that's been derived from... Oh, sorry, I'm just seeing somebody motion to me at the back. So we have the Lynch Syndrome Hubs, which ensure that the correct management and cascade testing occurs. So in our geography, we have two hubs. We have one hub at Cambridge, which covers the east of England, and we have one network across East Midlands. So the purpose of our Lynch Syndrome networks are to ensure that the carriers get the best management, so that they are told about aspirin, they are told about H. pylori. We have the oncologists at the moment tell us about immunotherapy, but very soon I'm sure there'll be other options. So the cutting edge technology is available to all Lynch carriers, not just the ones that are lucky enough perhaps to see somebody who's an expert in the field. It's also a repository of information and expertise. So in genetics, we like to have complicated cases, complicated situations. When that happens, these people are discussed at the hubs. We also will have, and I'm quite excited about this, a multidisciplinary clinic for all carriers. So what that means is that anyone with Lynch syndrome can come and talk to a surgeon, an oncologist, a gynecologist, genetics, anybody who they need for their treatment all on the same day. So they're not having 5, 6 different appointments at different times, different places. It'll all be there on the same day, and everybody's able to come and get that information. So the next step in the pathway is we've had the project, we've established that we've screened everyone for Lynch syndrome, we've hopefully identified as many Lynch syndrome carriers as we can, we've ensured that their management of cancer is targeted based on their inherited condition, and we've referred them to the new Lynch hubs to make sure that they're managed in the best way possible, and also to make sure that their management in terms of colonoscopies happens automatically. Historically, people may not have had colonoscopies every 2 years, which is a really bad risk. We now have safety processes in place to make sure that they do get their colonoscopies and that they are appropriately referred. Once all of that has happened, you then have a person whose relatives have a 50% risk of having the condition themselves. So their brothers, sisters and children, if they're adult children, may want to have genetic testing. We therefore do what we call cascade testing. And cascade testing only happens in genetic services, and the reason for that is that it's quite an involved process. We would sit down with someone, ask them about their medical history, check their family history, and discuss with them whether genetic testing is the right thing for them. Do they want to know about this risk? And if they do, is now the right time? For example, if they're about to sit finals, we're not going to tell them that they have this risk. We would suggest that they come back after they've completed their exams. If they're about to get married, maybe now is not the best time. We talk through all the personal things going on in their lives and the timing of genetic testing, as well as the implications. One of the things that we talk about is the fact that if you have 2 sisters, there's a 50% chance that for each of them. So you could have one sister with the genetic condition and one without. And we talk a lot about something called survivor guilt, which is when someone actually gets good news, but their sibling doesn't. And actually they feel quite bad about that, or they can do. And we want to support them, explain that that's very normal, and talk through all of those implications, and ensure that when the family's gone through genetic testing, they're as well supported as they can be. We also refer for psychosocial support if needed. People often have difficulty understanding and processing this information, whether they have the gene alteration or whether they don't. And we need to be able to detect when people may have underlying risk factors for psychological problems, at which point we refer on for further support, either before or after testing. We also signpost them to relevant resources. The bottom line, of course, is when people are ready and appropriately counselled, we arrange genetic testing, and therefore hopefully identify people with Lynch syndrome, feeding them back into the management, making sure that we lower their risk of cancer, and if it does happen, that we pick it up at an earlier stage. So what have we done so far? I've told you about 2 projects, 1, universal screening for all Lynch syndrome, and 2, setting up the Lynch syndrome hub. In order to do this, we have identified colorectal and endometrial champions in every MDT across our geography, so across East of England and East Midlands. That means there's somebody in every MDT that should be thinking about Lynch syndrome, we hope. We have also ensured that MMR testing is in place across all the trusts. It wasn't initially, so now we have predominantly IHC, but some trusts do MSI. We've seen that the screening has gone from 21% for endometrial cancer in 2019 to 93%. So that's a massive increase, and if you think about the implications for those patients and their family, that's a massive change. We've also seen colorectal cancers gone from 51% to 93%. Colorectal cancer's had a bit of a head start. We've been doing this since 2017, whereas endometrial since 2020. But again, it's a big change. We've also seen that the reflex testing for methylation, so this is where it gets complicated. If your IHC is abnormal, I've talked about the fact that it could be sporadic or it could be inherited, you need to do methylation to determine which of those it is. And that has taken months, which is really unhelpful when you're trying to work this out as quickly as possible. That testing has now moved to Cambridge, which is our GLH, so the hub for our region, and we're hoping to see a much quicker turnaround time. We're also seeing mainstreaming in a lot of trusts, and we provide a lot of training nationally, locally, in MDTs. We've basically annoyed the MDTs so much that they think about Lynch syndrome when they see us, and that they've done a lot of external training as well. So every genetics service is now able, in our region, has uploaded historic data and is prospectively uploading patient data to the NDRS, so that colonoscopies will be nationally organised every 2 years. The national screening should start imminently, should have started in May, but there's a small delay, and the expert hubs have been set up across the region. What's next is we have our patient launch for the East Midlands network in September. Sally from MK and I are doing stock-taking meetings with every trust to check exactly where they are and make sure they're up to date. We're doing sustainability planning, and we're looking at pilots to extend to other tumour sites. I would now like to introduce Leanne Barratt, who is a brand marketing manager for Next. She's also a mother, and she has Lynch syndrome, and will be talking much more eloquently, I'm sure, than I have been. Thank you, Leanne.
Hello everyone. As Vicki mentioned, I'm Leanne Barratt. I'm normally brand marketing manager at Next, so very different day for me today. I'm normally looking at images and not dealing with bigger things going on, so very grateful to be here. I just wanted to chat to you guys about, as Vicki mentioned, I'm a Lynch syndrome patient, and how I discovered that I had Lynch syndrome, and also what that meant to me and my life and my family as an ongoing thing. So it was back around 10-15 years ago, my dad developed bowel cancer. It was quite far gone at the time. He had presented symptoms, been to his GP, but by the time it was discovered, he had a perforated bowel. He was quite poorly, and he was in hospital for a while in intensive care. Myself and my sister were visiting him. We had a good relationship with his doctor at the time, and we questioned about the hereditary link with the cancer that may affect ourselves, because our grandfather on my dad's side also had bowel cancer and bladder cancer as well. This was before sort of the new schemes that were in place as well with screening and testing, so we were picked up quite by chance, and Mr. Kelly had a link with Julian, I think, and referred us to Julian and the team in Leicester to go ahead with investigate genetic testing with the links and the risks associated. So we were counselled, as Vicki mentioned. We began the programme, and we went through counselling to sort of see if we were ready to go ahead with the testing, and how to make sure that we fully understood the risks involved and what it would mean for us going forward. It was some time we went ahead with the testing, and as you said about the survivor guilt as well, ironically, when we were given the results, we were discussing sort of best case scenarios, obviously that neither of us had it. Worst case scenario for both of us would be that both of us had it. But for me at the time as well, it was that a big thing was if my sister had it, because she had a daughter who was around 3 at the time, whereas I didn't have children, and the risks associated if she had it. My niece would also have it. But when it came around, it turned out that I did have the Lynch syndrome. I'd inherited it from my dad, whereas she hadn't. And she was the one who took it worse at the time than I did. And we laugh about that now, but she's always been a part of it with me, and she's definitely been a taxi when I'm going to and from colonoscopies as part of the survivor guilt. I've played on that as well. So, but what it means for me going forward as well is obviously knowing that I have Lynch syndrome. I began the regular screening program, so I've ultrasounds, colonoscopies regularly. I'm very lucky in that I've been given the support that I have through Julian and the team in Leicester. And I know it's not the case for everybody nationally as well, so I feel very fortunate that, one, I've been picked up, and two, that I have the support that I have as well. As Vicki mentioned as well, I was aware when I discovered that I had Lynch syndrome, and knowing all the information up front and what that would involve and mean to me in my life, when the time was right, I met my partner, and we decided to go down the PGD route as well, to eliminate those risks, hopefully, from any children that we have. So that was 2016, we decided to go ahead with PGD. Luckily, we were referred to Guy's down in London, Guy's in St Thomas. And in 2017, we had our son Jasper, who's now 5.5, an absolute joy. And we realised how lucky we are that we were in the position that we could make that decision and have him in the way that we did. Although it was a nightmare going out the door this morning, getting ready for school. So we're very blessed, but it was an absolute pain in the bum this morning, bless him. But it's just an example of knowing all of the information and making those choices myself. And I know, looking at the statistics that Vicki's just shared, I'm one of the lucky people who are aware that I have this and I can make those choices. It wasn't great news when I found out, but I feel privileged to know that and have this support as well. And for me as well, going to the colonoscopies, particularly when I was younger, sometimes I felt like I had to justify almost while I was there at the time with the different touch points throughout the NHS, whereas I think awareness and research that's going on, it's definitely helped in the last sort of 10, 15 years that I've been experiencing it. The awareness is definitely coming through, and I feel, particularly when I was visiting my midwife, and she'd been trained on Lynch syndrome, and as soon as I walked in the door, she went, "Oh, Leanne, I've been looking forward to seeing you. You know, you've got Lynch syndrome. I've heard all about it." And straight away, that put me at ease, rather than going, "Oh, this is my story. This is why I'm here," and justifying that treatment and that screening as well. So, I think understanding. There's two things I sort of want to take away from it. So, understanding for me all the different touch points throughout the NHS, like what you guys are doing here in the room today and talking about the future, is amazing for me that there's so many more people who are going to be aware of this when I visit them, and it just makes you feel supported. And also, it isn't a bad thing necessarily. It's not great. Obviously, you've seen the risks associated. I myself am MSH2, so it's the greater risks in certain areas. But it's gives opportunity as well, I think, for bettering my chances in the future and my family's chances. So it is a blessing in disguise, in a way, of discovering this. As part of the PGD, we did have another embryo as well, which we decided to give a try in 2020, which was a great year that it was. And unfortunately, that one didn't work. So we were faced with the choices to make as well. So whether we underwent another round of IVF or whether we were to go ahead and look at taking our wins, basically. So as part of understanding the risks associated with gynae cancer, I also had some regular screenings around the time that I got the second embryo didn't implant. And there were some flags on there with some irregularities, and it was that time that we kind of had a chat about it to say, do we go ahead and try again, or do we, as I say, take our wins? And we decided that for us as a family, it was best not to try again and have any more children, but also I took that opportunity, and we'd previously discussed having hysterectomy at some point in my life, but I've hit the age now, I'm past 35, where the risks start to increase quite rapidly. So I personally took the decision, and I underwent a hysterectomy in February this year, just so that I could eliminate as many of those risks as possible, and also just to give me and my family the best chance in the future of having a happy life together. So it wasn't taken lightly, but again, just the education and the knowledge that I've been given from the support that I've got has helped me make that decision, and I felt that was right for us at the time. So that's where we are now, but again, it's just to take positives and have an understanding of everything, basically. So in a nutshell, that's my story. So thank you very much.
Hi, good morning. This morning I'm going to talk about whole genome sequencing in childhood cancer. And the evidence that this could add value to the clinic was really provided by the 100,000 Genomes Project. So briefly reviewing our experience there, we sequenced 36 childhood cancers from 23 different cancer types, predominantly those derived from the central nervous system brain cancers. And the 36 cases are depicted on this slide here. The colours indicate the particular cancer types that we looked at. The sex of each case is stereotypically depicted by the presence or absence of a ponytail on these cases. And the mutations that were identified by standard of care testing are depicted by these solid stars for somatic variants or open stars. So these were what was already known in these cases. Then we performed whole genome sequencing, and the additional variants we identified are depicted by the same stars above the patients. So an extra harvest. Almost all cases have at least one additional variant. So when we tried to determine the clinical value, we looked at the value conferred exclusively by those variants identified by whole genome sequencing. And that's summarized on this slide here. So diagnostic information was available in about 17% of the cases. Prognostically informative mutations were found in about 20% of the cases. And variants which could inform or provide additional therapeutic opportunity were seen in about 30% of our cases. So we could evidence the value of whole genome sequencing via this 100,000 Genomes project. Now, post 100K, genomes are now a routine part of clinical service. And this timeline depicts the types of clinical indication that we perform whole genome sequencing on and the time which they were onboarded. So via our experience of 100K pediatric cancer, we could onboard this quite early in 2021. Now, within the East generally, there's a good appreciation of the value that whole genome sequencing can provide in cancer care. And as a consequence, it's quite widely adopted, including in pediatric cases, which is the large pink bar on this graph here. And in the East, we actually sequence more pediatric cancers than any other GLH geography. So we put a lot of resource into this endeavour. And this graph hasn't showed properly. What this graph would show is that since the 100K project, the time taken for genomes to be delivered from a GLH back to a GLH, so the sequencing and analyses of the data has decreased dramatically in time. So it used to take about 3 weeks, and now it takes routinely just 2 weeks. So it's becoming a competitive assay with respect to time. So this was all very good. Our 100K study illustrated the value, but it was based on, there was some bias there. It was selected patients where there was a consideration that they might be, genome sequencing might add particular value. So via routine services, what we wanted to explore is what's the benefit to patients in an unselected way. So we have a pediatrician, a trainee pediatrician who's been looking at the data that we've derived via routine service, and to assess if the positive things we've seen in 100K extrapolate to routine service. So what Sarah's looked at is all patients that have presented to the CUH pediatric unit across the last 18 months or so, 2 years, and determined what happened to those cases. The impact, the clinical impact, is defined as changes to diagnosis, prognosis, or therapeutic opportunity. And again, we can explore the turnaround times via routine service. So what this chart is showing is the types of cancer that were recruited via routine service. Blue bars indicate those where they were recruited at diagnosis, and white bars at relapse. And similar to 100K, the most frequent referrals were cancers of the CNS and sarcomas. Neuroblastoma was the most frequent individual cancer type. This bar indicates that the age profile, so most cases were under the age of 12 when they were recruited. And what this graph shows is the turnaround times. So to explain this graph in a bit more detail, the grey bars are the time taken from when we send the DNA out to when the report is returned to us from Genomics England. And as I said, that has decreased over time over the last 2 years. It's about 2 weeks. The orange slither on top of that grey bar is the time taken for us to analyse the data and to disseminate the clinical value to our clinical colleagues. And that's quite a small little component of the turnaround time. So our team are very adept at analysing the data, and they will take them to the nearest available MDT to make sure that we transfer the information quickly. The more problematic area is the green bars behind, the green bars that are at the bottom of the graph, and that's the time taken from consent to the time taken for the DNA to be sent out. So there's much more variability there. There's some cases where we can see it can be very short, so the overall time for a genome can be as small as 3 weeks, which is very similar and competitive to other more targeted, less valuable assays. But clearly this is the case, this is the area where we can really aim to improve the turnaround times more generally. So what are the sorts of cases, what are the numbers of cases that presented to our unit? So in total, there was about 143 cases that presented over the last 2 years. In 45 of those cases, whole genome sequencing wasn't performed because the sample was not appropriate or it wasn't clinically indicated. In the remaining 98 cases, most, 87, were offered whole genome sequencing. And this slide shows the reasons why, in those 45 cases, the reasons why WGS wasn't offered. So frequently it's because the sample wasn't large enough to be able to derive enough DNA to send off, or it may be that there wasn't a biopsy taken, or a biopsy was taken elsewhere within our region so we couldn't access that sample, or it just wasn't clinically indicated, it was a benign tumour, for example. Now, so there was 87 cases collected. There was a feasibility study that we provided, at the very start of the endeavour, where we sequenced 23 cases. So all together, there was 110 cases that we've analysed to determine the clinical value via routine service. And in 1/4 of those cases, we were able to measure clinical impact exclusively via WGS. So that clinical impact is provided via germline mutations in 8 of the cases and via somatic mutations in 19 cases. And that clinical impact is defined in this slide here. So diagnosis was changed in 2 cases or modified in 10 cases. Prognostically informative information was provided in 7 cases, and treatment was actually changed in 6 cases, or there's variants that provide prospective therapeutic opportunity in 9 cases. So the same things that we've seen in WGS were recapitulating via routine clinical service. This slide just shows the germline variants present in the whole genome sequencing we performed. The green ones were already known via standard of care. The red ones were informed exclusively by WGS, many of them unexpected. And I'll use some of these germline variants to present 3 cases just to illustrate the clinical impact on our childhood cancer cases. So when we perform a whole genome sequencing, we produce a graph that looks something like this. Each dot is a cancer from an individual, and the height of the dot on this graph, or the position on this graph, indicates how mutated, how many mutations are resident within that cancer sample. So increasing indels are on the y-axis, increasing subs are on the x-axis, and the diameter of the dots indicates the numbers of structural variants in each case. So what we can see, if we look at the bottom left proportion of the graph, there's some cancers where we just see a handful of somatically acquired variants, hardly any, and it's quite easy to find the causal variants in that case. And by contrast, in the top right-hand corner, we see cancers which have got an extraordinarily high number of somatically acquired variants. So the glioblastoma in the top right has over 1.5 million somatically acquired variants, yet the cells are still viable. In fact, they're thriving. So we can look to see what's this difference. So we can take two cases as illustrative with an elevated TMB, tumor mutation burden. So here I'm talking about two cases. One's an ependymoma and one's a glioblastoma, both childhood brain tumors. And these tree graphs on the right here indicate another depiction of the tumor mutation burden. So if we look at the number of indels, each square is a box of one of the 100 cases. If we look at the number of indels, we see a much elevated frequency of indels in these two tumor samples, the purple being the glioblastoma, red being the ependymoma, compared to all the other cases. So this is suggestive of mismatch repair deficiency. If we look at the numbers of substitutions, we can see that in the ependymoma, it's unremarkable, but in the glioblastoma, there's a vast excess. Now, when we add this general information about these cancers to the actual variant data, we're able to establish a diagnosis of congenital mismatch repair deficiency, or CMMRD, in these two cases. And this is caused by biallelic mutations in mismatch repair genes. We've heard about Lynch already, where we have a single germline variant. In these extreme cases of early onset tumor, there's two mutations, two inherited mutations. In the ependymoma, those mutations were in the PMS2 gene, a point mutation and an exonic deletion. And then in the glioblastoma, they were resident, there was a homozygous mutation in the MSH6 gene. So one question remains is, why does this glioblastoma have this massive excess of substitutions compared to the ependymoma when they've both got the same diagnosis? And that can be explained by this paper here, where we can study cancers, and in cases of CMMRD, there's additional acquisition of somatic variants. And if one of those variants resides within a gene called poly, you get this ultra-hyper-mutated phenotype. So when we compared our case to the cases within this paper, we've seen a very, very similar picture. A bland genome with respect to copy number variants, but a huge excess of substitutions, confirming that this is the same within our case. We can, of course, look within the data for the causal somatically acquired polyvariants. There's a whole load of polyvariants in this tumor, because in every gene there's lots of variants because it's so hypermutated. But we see one of the variants at codon 459, which resides within a certain domain, which confers this hypermutation phenotype. So what does this mean clinically? In the ependymoma, we can confirm a diagnosis of CMMRD, informed by two mutations in PMS2 and a global picture of hypermutation. In the glioblastoma, similarly, we can see a CMMRD conferred by homozygous MSH6, and an ultra-hypermutator phenotype illustrated via the presence of an additional polysomatic variant. So for the patients, this provides opportunity for immunotherapy. Cancers which have lots and lots of mutations can respond well to that type of therapy. Obviously, there's germline follow-up. To my knowledge, there wasn't a suggestion of Lynch syndrome in these families prior to the presentation of these cases. The hypermutation as a global feature is suggested of this CMMRD diagnosis, and this ultra-hypermutation can only occur with this CMMRD plus poly. So the general picture, in addition to the variants, enable us to really secure what's going on in these cases. I'm going to move on to another vignette. This is Baby Oliver. Baby Oliver is more famous than he realizes. He's been all around the media, he's been on the radio, he's presented at a national conference twice. So he is kind of by definition the poster child of genomics within the east of England. So I'll just flesh out a little bit of what Sue mentioned in this case. Prior to birth, a mass was identified in baby Oliver's thigh. After birth, it was confirmed on MRI. In 13 days of life, a biopsy was taken by the pediatric oncologist and sent for whole genome sequencing and routine pathology. The routine pathology suggested this malignant type of cancer, this fibrosarcoma. So via the WGS, we were looking for a sort of variant consistent with this malignant type of cancer, fibrosarcoma, which is a variant in a gene called NTRK. However, we didn't find that variant in that case. However, what we did find is a mutation in a gene called PDGFRB, which is associated with a much more benign lesion, a much more benign phenotype. The mutation is shown on this slide here. It's very subtle, and the key thing to say about this mutation is it would only be found by whole genome sequencing. It's the sort of variant that wouldn't be visible by a targeted assay. So Baby Oliver was fortunate that we were able to find this mutation because whole genome sequencing was offered. As a consequence, treatment was changed from chemotherapy and surgery to just monitoring, visual inspection. And since that initial diagnosis, the mass has spontaneously regressed. So on the left is the size of the tumour on presentation, on the right is the size of the tumour today. So that's a really good outcome and an example of how whole genome sequencing prevented unnecessary treatment. My final case here is a case of a neuroblastoma, so one of the most frequent cancer types that we come into contact with. And this was found in a 4-year-old presenting with leg and back pain. Staging and histology suggested a neuroblastoma. There's markers we can pursue in neuroblastomas. In this case, it suggested it was a tumour with potentially a poor outcome, so treatment was going to be required. In addition to those variants, we found a PALB2 germline mutations. We would never normally screen for PALB2 germline mutations in a case such as this, but the genome delivers everything, so we get to see these sorts of mutations. The role of PALB2 in neuroblastoma is controversial. It may have a role or it may not. Irrespective, it's a breast cancer predisposition gene. So the clinical intervention that was afforded in this case was when applying radiotherapy, the radiologists avoided susceptible breast tissue when applying this treatment so that it reduced the risk of any breast cancer risk later in life. So, just to summarize, we've implemented routine paired whole genome sequencing within our pediatric unit. Every patient who is appropriate gets afforded this test. The clinical management shows that it impacts a significant proportion of patients. It's a worthwhile endeavour. In addition to this clinical rule, it provides lots of opportunities just to increase science generally, to add insight to certain types of subtypes of certain cancer types or germline predispositions. And it also has the potential, if we can get that turnaround time down, it has the potential to replace sequential standard of care testing into a very singular, highly informative assay. So I'll end there other than to acknowledge all the staff within the East GLH which contribute to this work. Sarah Leiter is our paediatric oncologist who's putting this all together, and it's really only been able to be a successful approach via a really concerted adoption of this test by paediatric oncologists, clinical geneticists, our pathologists, and our clinical scientists. Thank you.
Yes, I appreciate I'm between you and your coffee, but we've heard lots and lots about personalised care, and in particular with cancer, everything that's changing in terms of personalising the treatment that we give to make it more specific to patients. And I think we've got our clinicians to thank for that. What I'm going to focus on a little bit more is the other side of things, which is making the drugs that we've already got that little bit safer. So I'm going to be talking, so medicine safety is a really highly reported category of patient safety incident if you're looking at the national data. And essentially what we're talking about here is we're trying to reduce harm from medicine's use. So this is very much the medicines we've got, how can we make better use of them, how can we indicate the correct sort of dosing and support for patients. There's a whole range of information and groups that support this. I'm going to just pull something up from Medication Without Harm, which is the World Health Organization's push for medicine safety. And you can see there's a range of areas it looks at, including patients and the public, healthcare professionals' involvement and understanding of medicine safety, the medicines themselves, so looking at some of the more basic things like how the medicines are maybe labelled so you don't give the wrong thing, and then the systems and the practices that we can sort of change to make the medicine safer. And just to give you an idea of the scale of the problem, there is a significant burden to the acute secondary care in terms of adverse drug reactions causing admissions to hospital. The estimates of the spend on additional costs due to adverse drug reactions is £2.2 billion. So it really is a significant issue for the healthcare widely. And I just wanted to put a couple of bits up about something called medicines optimization, which is kind of related, but is another thing that we're looking at in terms of, as well as reduced side effects, trying to pick medicines where people are getting the best effectiveness, the best impact from their drugs. And you can see that the medicines that we use and the way that we use them, so typically a patient would come to see their GP, come to a clinic and be prescribed something that's called a first-line drug. It's the one that we use most commonly. And then if they're unable to tolerate that, we try a second one, we try a third one, we try a fourth one to try and manage their condition. The other aspect is, that, again, the cost of drugs to the NHS, and actually medicines optimization might be able to help with that. And you can see I've written out 17.8 billion deliberately with all the zeros. You just get a real feel of quite how much we're spending. So the other aspect to bring into this is personalised medicine, and here I'm really focusing on tailoring treatment to individual characteristics. We've heard a lot about that in cancer in terms of the tumour expression and targeting that. But I think it's also right to think about the right medicine based on how an individual will react to it, so what the body is going to do the drug. And we've got a great example in cancer of DPYD, which I'm going to talk about. It's been a real success for the NHS, as Sue mentioned right at the beginning. So you can see here, I've got the use of fluoropyrimidines is not as much as it used to be. But these is a specific type of chemotherapy that is used, can be used for a number of cancers. It's not one of these smart targeted chemotherapy regimens, but it's chemotherapy that's a bit broader targeting. And we know that patients who are deficient in an enzyme called DPD have a susceptibility where they don't metabolize the class of drugs very well, and therefore they can get toxicity, and this can be fatal. So we know that if we test for the DPYD gene, which is the gene that codes for that enzyme, we can then make suggestions around reducing the chemotherapy dose or suggesting an alternative, and that can have good positive outcomes. And you can see on the right-hand side, we're delivering many DPYD tests. So that's across England, across the whole GLH, and the East GLH is massively contributing to that. We have very good figures for that. And it was really good. We did some work a couple of years ago just to understand how the process was done. And from that, there's some data about how many tests we're doing, and therefore you can impute that we're actually avoiding deaths and reducing the number of patients who would get complications from the drugs. So a really powerful story, real success of how we can use this precision medicine to make the medicine safer. As I mentioned, we did some work as part of a national project, and I've just highlighted some of the successes and some of the opportunities that we have around this area. And in particular, we have shown that DPYD testing is completed across the whole of the region, but we're also aware of some of the limitations in the way that the information is reported back and what happens to that at a local level. So we've got a bit of variability between reporting results back electronically or it coming as a PDF, which then goes to a secretary's email, which then goes somewhere and then ends up in the notes and then gets acted. So we've got a bit of work to do, and we're looking to work nationally to get a system where we can get the results direct from testing straight into the prescribing record, so we can really influence that and we can start to put that information where the clinicians really need it. There are some other areas that we can think about in terms of personalised medicine. And one of the areas that we need to improve on, obviously, is the outcome data for chemotherapy drugs, and making sure that we're gathering this information on the benefits that patients are getting, both from personalised precision medicines and targeted treatments, but also ongoing implementation of tests for other genes associated with complications and side effects from drugs. So I've got some examples here where TPMT and NUDT15 are two genes where we're just bringing that in for adults. It already is on in testing for pediatric patients, and that can influence a drug called mercaptopurine. We have been doing some work around a variant in the mitochondria, which predisposes patients to hearing loss because of aminoglycosides. So that would be gentamicin, kanamycin, as we saw in an example from Julian. And so we're trying to sort of really pin that down and support patients with that. And then we've got some very exciting developments coming. So one is gene therapies, which you will be, some of you will be aware of, but is really expanding at the moment. It's going to be very powerful, and we're just working through how we would deliver that as the NHS. And then this idea of testing patients before they get medicines across a range of genes that we know will impact drugs that they might be on. And so there's a PREPARE trial which was completed in the Netherlands and led from the Netherlands and completed around Europe predominantly, which has shown that we can reduce the side effects of medicines, so these adverse drug reactions, based on pharmacogenomic data. So that's genes which influence drugs. And again, we've got some work going on, which is about to start in the Northwest, which we'll be involved in as well in the East, a study called Progress, and that's going to be really exciting, showing how we can do that within the NHS. One of the areas I just wanted to comment on is a bit of a contrast. I appreciate it's not entirely related to cancer, but there's a very interesting area around hypersensitivity reactions. So there are certain drugs that you can get, which you can receive, which your body then has a risk of developing quite severe toxicity, and in particular we talk about these things called Stevens-Johnson syndrome and toxic epidermal necrolysis, which are horrible, horrible skin manifestations. So we can test for the genes in HLA, so that's a human leukocyte antigen which is involved in that response, and we can make sure that we're trying to avoid those drugs in patients with variation in those genes. And you can see examples on the right-hand side again. We've got national recommendations on genetic testing before starting certain drugs such as abacavir, carbamazepine and phenytoin. Again, trying to get some data on what we've done in terms of improving, reducing the side effects and the sort of patients presenting with reactions is difficult to get. So there's a challenge there to make sure we're reporting on that. And so going forward into the next year and beyond, what are we doing that we can really impact? So I mentioned Progress, and that's going to be a really important piece of work for the NHS. I mentioned about testing for these mitochondrial variants in aminoglycoside-induced hearing loss, electronic prescribing and making sure that we've got the results in the right place when we need them. And you've heard a lot about personalised medicine in terms of targeted therapies. In terms of some regional work, we're looking very strongly to look at how patients are consented and engaged in terms of information on pharmacogenomic tests, potentially looking at DPYD. And again, looking at how we can develop the workforce and make sure that we're using all the tests that we have available to us and that we're doing the right requests and that we're thinking about how we monitor those. I think I'm ahead of time, which is a bit unusual, but there you go. You can all have coffee. I think it's very much a huge area which is difficult to distill into a short presentation. So that's why you've got it, and I'd welcome any conversation afterwards.
Okay, so yeah, I'm Robin Lowe, biomedical scientist at the Norfolk Norwich Hospital, and for 12 months I've been on secondment to GPAP working with Dr. Mohammed Ahmed. And it was suggested that before I sort of get into the main body of the presentation, I should sort of give some background on GPAP and what we've been up to at Norwich over the last year or so. So these are GPAP's aims, but they can actually be reduced, I think, into two themes. Firstly, understanding what is happening to specimens as they flow from patients through testing and diagnosis into reports for clinicians, and generally aiming to identify areas of weakness, bottlenecks, and so forth, any other mistakes that are going on. Secondly, it's really about forming contacts between hospital laboratories, the genomics hubs, and other stakeholders in the region. Again, to sort of discuss shared problems, find out solutions, consider best practice, and see what we can learn from each other and help each other with. The emphasis, of course, is on molecular and genetic testing, making it as robust and efficient as possible. So these are some of the things we've been up to this year, so I won't go into all the things, but in particular there are the Lynch audits that I'm going to discuss further, and our work with the Lynch Syndrome Testing and Surveillance Group, which has been ongoing throughout the year, which I've found very rewarding actually. In the course of the year we also saw our first specimen for whole genome sequencing, and despite a little bit of stress it caused in the lab, it went smoothly, and we actually received the report back last week. So hopefully we'll have further discussions about that in the future. But very recently we've also contacted 3 other hospitals in the region with a questionnaire, sort of asking them about their experiences with molecular and genetic testing. And we've even had one of them complete it and send it back to us. So hopefully we'll get the other 2 at some point, and that will lead to some fruitful discussions. So when we started this, we thought, that's the wrong one. Where's it gone? Sorry, I jumped too fast, I think. We thought we really ought to know what was happening in our own department before we went out to other labs to discuss things. So Mohammed suggested that we look at Lynch syndrome, since we were already doing some work with the group, and that's where we kicked off. So yeah, initially we looked at colorectal cancer, Lynch and colorectal cancers, and then we moved on to endometrial. But I also started this year by looking at all the specimens we sent out of our department for external testing in the whole of 2022, and that threw up some related but unexpected errors. So. Now this is what we're auditing against, the Lynch syndrome diagnostic pathway, and this is a modified version of the NICE guidelines. This one's specifically for colorectal. The difference with the endometrial is that we don't do the BRAF mutation testing. Now, like I say, all new cases of colorectal endometrial cancer should be tested for Lynch syndrome. We wanted to know whether or not cases were entering the pathway and then flowing through it correctly. Now, I'm not going to go through, obviously, this in detail, but there are sort of 4 tests in the pathway. First, testing for mismatch repair status, then for BRAF mutation, which, as I said, isn't included in the endometrial pathway, and then for MLH1 hypermethylation, with a final test for actual germline whole genome sequencing to confirm Lynch. The thing is, most patients don't have Lynch, so the result of each test really determines whether or not a case progresses further down the pathway, until it becomes sort of increasingly possible that the patient has Lynch syndrome. Then we can sort of advise clinicians to refer the patient for germline testing for confirmation. So the audit itself. Right, you want to look at the green lines here, because these are the testing steps in the diagnostic pathway, and in particular you want to look at the percentages in the green lines on the right. Now, ideally, all of those percentages should be 100%, meaning that every case that should have undergone that particular test did get tested. However, as you see, it starts well, but there is a clear reduction as we progress through the testing pathway, especially when we get to the germline testing. And again, this is the endometrial audit, which again starts very well and stays not too bad, but then it drops off again when it comes to the germline testing. So we expected cases to slip through the net, but we also had some unexpected errors. And perhaps most significant of these included not actually following the pathway in sequence. And we had a case where was sent for MLH1 hypermethylation. No result was received, and nobody ever chased up where the result had got to. We also had peculiarities, which I discovered in the audit I was talking about earlier this year, where clinicians had contacted the secretaries in our office for MMR testing. Now, we test MMR in-house, but these were sent off to other labs for testing. That's perhaps because our secretaries are unfamiliar with our full repertoire of tests. So, there's a lot of things we do. Now, these only represent a handful of cases, but they're still mistakes nonetheless. So why are they slipping through untested? Why the unexpected errors? Now, this could simply be down to lack of awareness or understanding of the pathway, which we hope wouldn't be the case. But there might be a misunderstanding in terminology or our general lab processes. And this could be not just in the lab, but also on the clinical side as well, because they're the ones who will ultimately do the referral for whole genome sequencing. However, it could be very easily down to simple forgetfulness. Even pathologists are human too. And they are faced with frequent interruptions and distractions, with colleagues coming to knock on the door, ask for second opinions, trainee paths wanting, advice and guidance, or even biomedical scientists like myself coming in and asking them to fill in forms correctly. And on top of that, there is always another tray of slides, another MDT that demands attention. They're constantly under pressure, so things slip. This one you'll all know about, weaknesses with IT, lack of integrated reporting and test requesting systems, different systems that don't talk to one another, and quite possibly in our case, failings with our tracking systems, which may be a process issue rather than IT, but it's still a possibility. But you all work with computers, you all work with umpteen IT systems, you know there's problems. So, how do we move towards 100% compliance with a testing pathway? Well, you keep raising awareness. You perform the audits, present the audits to the pathologists, then you tell them you're going to repeat the audits in 6-12 months' time and see if anything's improved. And you can discreetly follow up errors and anomalies with the people concerned. I've also done things like provide nice, colourful, laminated copies of the pathway and guidance on when to refer cases. Another idea is to look at improving reporting systems, such as standardised proformas that emphasise the testing pathways. I mean, ideally, I'd like to see a test request mechanisms embedding within the reporting schemes. Imagine just be able to right-click there and then on your report, bring up the extra work testing, so that you can immediately request MMR status performed. Of course, we also have the role of the Lynch champion, which has been fairly recently created, and people are in place in our hospital now doing that. But they're people who can chase up both sides, on the pathologist and the clinical side, particularly at MDTs, and make sure that people that need to be tested are tested. Now, I was going to stop here, but I think I will talk a little about something that cropped up in the course of conversations with clinicians. One of them said, we don't particularly have a great deal of time to keep checking reports for supplementaries. And they said what they really wanted was a monthly list of patients that required genetic referral for Lynch. And they're obviously very keen to avoid missing these patients because there's clearly health implications. It's important for preventative medicine, and one of them pointed out to me there's also potential legal implications as well. So this is important not to miss. So I had to think about this, and I knew from some other parts of my work there are these things called SNOMED codes, which is, I don't know if it's just a curiosity. Show of hands, who knows what SNOMED codes are? So what, that's 50% maybe? Basically, there's a huge number of codes which are attached to medical conditions, medical interventions, surgical techniques, all these sort of things. And I knew you could create new ones, at least in the old system. So I thought, why don't we create a new one? When a path has a case that needs genetic referral, they can add that SNOMED code to the report, which means that our IT guy was able to use business objects to run a search for all the SNOMED codes and then send out an automated monthly email to particular groups. So we've got it set up that on the 1st of every month, an email goes out to the colorectal team at JPH, the endometrial team at JPH, and the same at the Norfolk and Norwich Hospital. and that sends them out an Excel sheet with these patients, we advise genetic referral. And that's been running for 3 months now. It seems to be working, it's well received, and the biggest challenge is constantly updating the email distribution list, because that seems to change every month. And these are just the benefits of being able to make sure that things get referred. These emails go out. Is that it's regular. The teams know when they're going to get this information if it's required. They don't need to keep asking for it potentially. And of course, then patients start entering the system faster, and hence the families enter the system faster. And of course, all very important, more auditing and planning and building case build information. If you've got cases tagged with this, you can search them, you can say how many, things like that. I should quickly wrap up with some thanks to various pathologists in our department we've had long conversations with. Ray Lonsdale, Alexia, who I love dearly, but I still can't remember how to pronounce the surname, Virginia Sams and Mohammed. Will Potter was our IT guy who got the SNOMED going, found the audit data, I should say, and helped with emailing out these genetic lists. And Ian Sherris for creating a new SNOMED code. Any questions later on, just catch me. I'm fairly distinctive. Yeah, I'm here all day. Thank you very much.
Thank you very much indeed. The Sudden Unexplained Death pilot program is one of the national transformation projects that Sue Hill discussed or mentioned in her talk this morning. It's been an enormous privilege, certainly for myself, to be taking part in this. It's very much a multi-stakeholder particular program of work, which in the East and together with the South East GMSAs we've been leading in partnership with the British Heart Foundation, the patient charity Cardiac Risk in the Young, but also with the Royal College of Pathologists and Chief Coroners, NHS and Genomics England. So this is a very significant piece of work. But why sudden unexpected death in the context of the Genomic Medicine Service? We understand about sudden unexplained death in terms of, we know a definition, a witnessed spontaneous death within an hour of onset of symptoms, or an unwitnessed death seen alive in the previous 24 hours. And we also know that in terms of cardiac causes, the majority of those are very sadly due to underlying ischemic heart disease, coronary artery disease. And to my mind, it is unimaginable to know how families cope with that very, very sudden loss of a family member, often a young adult. But it must be even more unimaginable if there is no clear explanation for that death, or if that death also signifies increased risk to other family members. So this is why it is starting to fit within the remit of the Genomic Medicine Service now. And partly that is because for those unexplained deaths, we know that a significant proportion of them have an underlying genetic cause. So when there is some structural abnormalities at the heart, such as heart muscle disease, cardiomyopathies, for example, we know that post-mortem testing in the research environment yields a very significant rate of diagnoses, so confirming the pathological diagnoses or perhaps allowing reclassification. And also we are aware more recently that when a sudden arrhythmic death has occurred, the heart is structurally normal, that we're achieving between 10 and 20% of a positive molecular diagnosis in those cases. But clearly, to achieve that diagnosis, you have to have access to post-mortem material for DNA extraction. So there are huge benefits to be now thinking about in terms of post-mortem genetic testing. So really, I want to sort of start the rest of the talk by just putting into context the potential benefits of this. And this is an anonymized family that they have given their permission for use that has come from Professor Elijah Bair's clinic in South London. And Elijah is the overall principal investigator around this particular project. And this was very sadly based around the sudden death of a young girl who was woken up in the morning by her alarm and was then found dead. And that sort of sudden loud sound trigger is very well recognized in a group of inherited cardiac arrhythmias called long QT syndrome. But fortunately, the family were willing to take part in a research program. A DNA sample was obtained after a normal autopsy. And in terms of research testing, the underlying genetic cause of the suspected diagnosis of long QT syndrome was identified. But you can spot that there was a sister, and she had already presented with a history of collapsing syncope in response to the doorbell. And it was then went on to be shown that she also had the same variant, confirming a diagnosis of long QT syndrome, and she was placed on medical therapy. Unfortunately, she didn't fully respond to medical therapy and then went on to have an implantable defibrillator fitted. And since that was fitted, it has now discharged a total of 3 times. So I think there's very, very clear and obvious benefit to how this type of testing can impact very, very dramatically on families. And of course, we've spoken about 2 daughters. There's also the issue about which one of the parents and potentially other family members are at risk. So that is what we're focusing our conversations on. So the background to the National Sudden Unexplained Death pilot program is really that. It's about pulling cardiac pathology, specialist cardiac pathology, post-mortem genetic testing, and follow-up evaluation of family members together to be able to deliver that whole program of personalised medicine that we've heard about in terms of managing the families who've experienced sudden unexpected death due to a potential genetic cause. And obviously what we want to do is to identify the cause of death so that we can diagnose, treat and follow up and prevent further events happening in these families who've already been so significantly affected. And obviously what we were aware of at that stage, that there were pockets of excellence in the country where perhaps this was happening on a research basis, but there was very, very wide variability. So that was what was starting to drive this particular program. And of course, at the same time, with the development of the genomic laboratory hubs that you've heard about and the GMSAs, that created an environment with which a potential program could be delivered nationally across NHS England, and you've seen that map there. This is a particular program that took place across all the GMS geographies in NHS England. And you can see how these program was initially developed. It was 1 pilot site per region, and in the east of England that pilot site was in Leicester, and that was coordinated by Joe Lowry, one of our program managers who's in the audience today, who I'm sure will be very, very happy to discuss the program in a lot more detail. We had regional leads. We had Kathy Mason, our lead chief coroner, and Kathy Richards from pathology. And you can see how all of these centres pulling together to deliver that particular program, this pilot site. And we're now getting to the point where we've passed our 1 year time. So just to think about what the main objectives of this particular pilot program were, it was to establish that consistent pathology referral practice for sudden unexplained death, including the use of specialist pathology, so that these cases end up in the right place within the NHS to gain the maximum benefit from genomic testing, if that is relevant to them. And so it's also about establishing the routine tissue retention. That might sound very straightforward. It's not. In histopathology, to permit forward DNA extraction and storage for suitable cases so that you've got the material, you've got the DNA, should genomic testing be indicated for a family. If you don't save that, you have lost your opportunity for many families to secure that accurate diagnosis and risk assessment for other relatives. So the key part of that was to be able to link up the coronial system and the NHS pathways for the management of inherited cardiac disease, allowing them to access genetic testing and clinical evaluation. It's also about establishing the mechanisms for that standardized genetic testing and reporting via the GLHs, to do it in a timely manner so that you're generating the maximum benefit from families. So this, as you can see, is a pretty novel pathway. And to make sure that this is going to be scalable after the pilot study, also including a significant database component to that, so that we can not only identify cases done, but also allow us to start to link out to other family members across the country, because families are typically quite widely spread. And really sort of to develop and disseminate those best practice pathways for adoption across the NHS by generating a toolkit approach. And obviously ensure engagement and input from patients and their support groups, and I've already mentioned the group CRY, who've been absolutely instrumental in driving this programme forward. So case inclusion, just very, very briefly, these are sudden unexplained deaths reported to the coronial service, and they include cardiac arrest where resuscitation has failed, for example. And it's a very, very broad age range, although we see a lot of individuals affected with these inherited conditions tend to be younger age group, or where there is a very, very clear suspected cardiac genetic cause. And a lot of this falls under this term, sudden arrhythmic death syndrome. So in terms of how this has all been played out, I'm just going to go through this in a fairly high level. This was a complex system to set up. So you can see that we've gone all the way through from identifying the key stakeholders in the pilot sites, really starting to work towards how we can understand the legal framework around tissue consent, tissue retention and consent, making sure that those families are then signposted into the NHS. The coronial service is not within the NHS, so they don't use the same systems. Signposted in, how the coroner's office who are conducting this work can be adequately trained in this area, and that there is also access to expert cardiac pathology. A lot of that in this country has been funded by CRY, funded by a charity. It's not embedded within the NHS. And making sure the key people to facilitate this whole pathway, the ICC coordinators, are in post. And all of that has now been achieved across all of the 7 GLH sites. We've also got external evaluators in looking at this programme of work, as well as health economists as well. And in addition to that, the Royal College of Pathologists is looking at great detail about establishing a specialist cardiac pathology service. And this is our toolkit. I'm not going to go through all of this in detail, but it's been an enormous amount of work pulled together by the BHF and other individuals about providing that framework that we can just use to go out and support the service across the country. One key part of that is the generation of very high quality information for families, for example, and again, cardiac risk in the young have been essential in co-developing all of this work, and having this information, especially from the coroner's officer perspective, is an important way of establishing contact with families. And we've also heard Sue Hill talking about the test directory. In terms of the test directory, we now have genomic testing for the sudden unexplained death survivors now embedded, and a test that can now be formally requested through the Inherited Cardiac Conditions Clinic. And so a very high level summary of where we're up to now. We've certainly made huge progress in breaking down silos, in particular establishing communication and pathways between the coronial service and the NHS inherited cardiac clinics, increasing access to those clinics so families are now routinely signposted in. We don't necessarily have to follow traditional referral pathways. They can be signposted straight in, and a lot of that side of things can be followed up afterwards. And also acting as a catalyst for change, driving the revision of the Inherited Cardiac Conditions Service specification and starting to to participate with the Royal College of Pathologists, as I've said, in designing a specialist cardiac pathology service. Where are we up to now? Just in these first year, in the first few months, what you can see here is that we are now getting families flowing through this pathway cumulatively across the NHS. We've had about 40 families coming through, and that's resulted in nearly 200 at-risk family members being identified, and at least 80 of those are now going through those pathways and potentially not only being screened, but being offered genomic testing if appropriate. And of course, all of that needs to be used as a framework to start thinking about national rollout, because clearly what we're hoping is that the evidence will support this as a national service. Our focus still remains on the delivery of the pilot to generate the evidence. However, we have been tasked with thinking about that national rollout, and we're working together in the East GMSA and the Northwest GMSA to scope that out in more detail. Please do not try and read this slide. I've put it up really just in terms of what we've done is to identify the complexities of what this looks like to do. So when you start thinking of the coronial service sits under the Ministry of Justice, it's funded by local authorities, it's very hard to pin down where that money actually comes from. And specialist cardiac pathology services and upwards sit within the NHS. Some are under the control, if you like, of the ICSs. Some are under specialised commissioning. So pulling all of that together into a pathway that we can then roll out nationally is going to be a big task. But our motivation and commitment to doing that through the GMS is unwavering. So on that note, I'll finish. Thank you very much.
Hi there, I've just put my glasses on to read my notes. I'm Vaila Morrison, PPV panel member. I'm actually an architect, really by training, so absolutely not clinical at all. I'm here to talk about our own journey with my daughter through the rare experience. I'm a mum of two. Eddie's our ultra-rare girl, 12-year-old. And an equally unique but not so medically interesting 9-year-old boy. I'll just sort of start from the beginning. Eddie's condition wasn't something that we knew about when I was pregnant or even when she was born in 2010. She was born at 38.5 weeks, pretty normal, delivered by Von Toos, and we were in hospital for her whole first week because she needed IV antibiotics due to a meconium infection. During that time, a selection of symptoms presented themselves, which prompted an overnight in NICU, and the neonatal doctor ordered some ultrasounds, a skull x-ray, and some chromosomal tests before we were discharged. As first-time parents, some of these things didn't really mean a lot to us, and we didn't have much to compare our experience with. So things like midline head lump and Moro reflex, wasn't really something we knew a great deal about. A heart murmur was also identified as a hole in the heart, which would probably heal itself, although in the end it actually needed open heart surgery. So all the tests came back in normal range, and we thought, oh, that's a relief, and we're sent home with our new baby. However, gradually, Eddie didn't quite fit the typical baby world. Feeding was always difficult from the start, initially put down to the infection, but she continued to struggle with weight, and our house often resembled scenes from The Exorcist due to her chronic reflux. And it became apparent that she was missing milestones in her red book and falling behind her peers. So we had more tests, but more normal results. It wasn't ever really made clear that that's actually quite common to get normal results on the genetic tests that were available at that time. And in the beginning, I can see that it's probably not a great tactic to frighten new parents. But as we were several months down the line, knew we weren't meeting milestones, we were left feeling pretty confused. And even felt a bit paranoid. Individual professionals were all great and always asked if we had any questions, but at that time, how did we know what questions even to ask? So at around a year old, Ailey began to gather lots of medical specialists, referrals to therapists, and there began to be mentions of developmental delays and low muscle tone. So more tests and more normal results. I've tried to list here all the people that we've come into contact so far with, that beyond the usual health visitor and GP that you would expect with a typical child. It's calmed down a bit for us now, but in the early days it was pretty overwhelming seeing all the different people. And without any name, diagnosis, or even confirmation that there was a thing, we didn't really feel that we qualified to join in with any special needs activities or groups, and we felt very isolated. And it wasn't until quite later that we found SWAN UK, Syndromes Without a Name, which is a national online community, and then later Cambridge Rare Disease Network's Unique Feet Group, which is a local community. In 2012, Ailey was entered into the DDD study, a sort of precursor to whole genome sequencing, which looked at specific developmental disorders. And back in the olden days of 2012, genome sequencing took a long time, and in Ailey's case, it was over four years before they found a change on the CAT6A gene, and we'd almost forgotten we'd been on the study by that time. The diagnosis was confirmed by blood test, and we had a follow-up chat with genetics, who said as it was such a new diagnosis, there was not much known, and pointed us to some studies, but there was no pathway, and no rare disease clinic, so not much changed in Ailey's actual day-to-day care. Meanwhile, we found a newly found foundation based in the US, and a Facebook patient group. At that time, only 70 children had been diagnosed, but now the CAT6 Foundation supports both CAT6A and CAT6B conditions and lists around 500 people diagnosed across the world, including around 20 to 25 in the UK. Receiving the diagnosis has been really beneficial, because without the diagnosis, there's just no option but to react to symptoms. And actually, we're still sort of in that phase due to there not being much known about her specific condition, and continue to float around between different specialties. But at least there's something tangible, and as diagnoses increase, so does the potential for better research and better understanding of what CAT6 means. It also allows access to support networks and sharing of ideas and therapies, and pointing each other out new research to help our young people. Just want to briefly touch on this one, because I'm absolutely no expert, but I think it's really important that ethics is always discussed in any genomics dialogue, especially around increasing access to antenatal testing, which I know we'll be talking about later today. The rapid increase in knowledge is amazing, obviously, for things like cancers and heart disease, but it's also a little bit frightening for other diversity, and as a sort of inclusion advocate, I want to make sure everybody understands that not all genetic differences are negative. And it would be very boring if we were all normal. For example, I don't know what we would have done had we been given an antenatal diagnosis for Ailey. What would the narrative have been like about CAT6? Would her quality of life be brought into question? And whose perception of quality of life would that be? Ailey's got a genetic glitch, but that glitch makes her who she is, but it's not all of who she is. So it's therefore super important that disabled people, neurodiverse and learning disabled people, are visible in our community and that are part of these conversations, so that everybody has an understanding of what real life is really like, and not just the worst case scenarios and medical risks. So what now for us? Overall, Ailey's had amazing care, but there's obviously been lots of limitations on what can be done with the information that's around. and also coordination of that care. For example, all of Ailey's symptoms would be considered normal paediatric issues, so a lot of the time they weren't joined up until she got the diagnosis. And we always felt that we were being passed from one department to the other. And that's not changed greatly yet. At the moment, responding to Ailey's genetic diagnosis involves me, an architect, trying to decipher research information, mostly from the USA, and trying to cherry pick information that seems to be relevant for Ailey and palatable for the NHS system, which of course is very different because the information is coming from the US. Everybody's doing things very differently over there. So the onus is very much on us to push for referrals, request access to medications or therapies, and we've had mixed success in achieving things like that. For example, it took 3 years from her genetic diagnosis to actually get to see a metabolic consultant to allow us to try a supplement, which is actually seems to be really helping Ailey now. So yeah, it would have been great to have had access to that sooner. So we pretty much have that, this same word cloud of people involved, and there's no real lead clinician and no pathway as such. So it would be great to have someone who sort of took ownership of rare disease, even if it's not an expert in her individual condition, because obviously with so many, no one's ever going to be an expert in all rare conditions. I think it's also really important that awareness is spread generally among frontline professionals, like health visitors and people who families will come into contact with first, because I think there's still a real, people are still not aware that being undiagnosed is a thing, and that actually, you know, it can take a long time, even still, to get to whole genome sequencing and things like that. And yeah, so it's only kind of dawned on us as time went on, especially after meeting more and more people in a similar boat, that with children as rare as Ailey, clinicians and therapists probably haven't seen many of her at all, if ever. And that our own experience ought to form part of the wider picture for her care. And we've become more confident in expressing things that we think are relevant and things that Ailey teaches us about herself when meeting new professionals. And we want clinicians to know, certainly for us, that it's okay to say that you don't know, because we know that it's, you know, rare and complicated. And we want to work together because we're ultimately on the same side. We're on Ailey's side. So yeah, all we really want from Ailey's genetic diagnosis is to find ways for her to better reach her potential. That's me. Finished.
Thank you for the opportunity to present our work. My name is Gajweska-Knapik. I'm a consultant in obstetrics and fetal-maternal medicine in Cambridge. And together with Lauren Capacchione, we will be presenting work which we have done in East GMSA towards equal access for fetal genomic services for all fetal medicine patients. First of all, I would really like to thank Vaila for a beautiful talk and very inspiring and very much sort of towards what we will be talking here today as well. When we talk about fetal medicine and genomics, we do need to acknowledge differences of this specialty in comparison with other specialties. So in fetal medicine, we really have two patients. We have a fetus and the mother. And in fact, we manage both of them. The other difference is that we have a quite defined timescale for providing diagnosis, proposing management, and implementing management. Pregnancy on average lasts 40 weeks. However, if we think about fetal medicine and abnormalities diagnosed, we usually diagnose them at 20 weeks. So they are diagnosed by the sonographer at 20-week scan. So that means that it leaves us with a really short time to deliver care to the patient. And if we can imagine potentially two scenarios. One scenario that the patient is seen in the ultrasound department, sonographer performs a scan and sees abnormality. They send patients to fetal medicine department where the patient is seen within a couple of days. Fetal medicine doctor sees abnormalities, decides that yes, these abnormalities warrant offering invasive testing. The patient accepts invasive testing. The material is sent for microarray and exome sequencing, as there are a couple of abnormalities seen on the scan. And the result is with us back within 2-3 weeks. We meet within MDT, decide what would be the best, what would be appropriate options or available options for the patient, and work with the patient through the options, being optimization of care antenatally and making sure that the team postnatally knows what problem the baby has, or if there are serious abnormalities found, not continuing with the pregnancy. This pathway would take us about 4 weeks to propose patient management. Let's think about different scenario, that the patient is somewhere in a smaller hospital where the sonographer finds a problem. The sonographer asks the doctor who works for fetal medicine there to assess the baby, and the doctor sees some abnormality. However, this does look as something which would not have impact on baby's long-term outcome. They do offer patients amniocentesis and send this material for microarray. The result comes back in 2 weeks' time. The result is normal. So the patient comes for consecutive scans, and at around 28 weeks, some subtle abnormalities are diagnosed there as well. At that point, the patient is referred to the tertiary center. However, this patient doesn't speak English, and they don't have money for the transfer. They need to wait for the husband to have leave from work to go to the tertiary center. They get there on Tuesday afternoon, are seen by fetal medicine consultant who sees several abnormalities on the baby, discusses this with the geneticist, and they feel that this patient should benefit from exome sequencing. Because it is Tuesday, this test, the material needs to wait a week, because currently as it is done, the test starts, the pipeline starts on Tuesdays. So the material needs to wait a week to be processed. Then it takes about 2 to 3 weeks for the lab to produce the result. During this time, patient goes to labor, ruptures membranes, comes to the hospital with fetal heart abnormalities, and has cesarean section offered, and delivers the baby by cesarean section. The baby has obvious dysmorphic features, and the prognosis for this baby is poor. Let's think how many potential opportunities we missed here. We missed the opportunity to offer patient management or choice of management in pregnancy. We missed the opportunity for the team to be prepared for baby with problems being born. And we also subjected patient to the intervention, which was cesarean section, which means that potentially their choices for future pregnancies might be in some ways compromised. We decided that we would like to investigate or see how this care is provided within our region, because in fetal medicine department we see both these scenarios and we see everything in between. So there will be a little bit of this, a little bit of that, and not that many patients actually fit into the first scenario, in which the result is given within four weeks. To do that, we decided that we would like to map our region and find out which hospitals are doing scans, where they refer to, how the MDT structure is. We asked about acuities, so how many amniocentesis are performed or CVSs, and how many microarrays are sent and exome sequencing. We asked about pathways which were currently used, about patient and family support which is provided. We also asked about what is the provision for training in this multidisciplinary and multi-professional team. We did this through the questionnaire which was sent to all the hospitals in our region. We did get replies from all the hospitals, for which we are hugely grateful. Lauren will tell what we found.
Okay, so this is just a graph just to show what our units are broken down into. So we've got 4 tertiary centres, which are the ones which generally will send the R21s. And we've got another unit that's not a tertiary centre but is serviced by a tertiary centre. And then we've got 5 district generals with fetal medicine services but not tertiary centres, and then another 6 units which are maternity units, but they refer all of their fetal medicine services out to tertiary centres off straight away if there's any signs of any kind of scan abnormalities. So this is just to show some information about how the MDTs are made up within all of the areas from the feedback that we had. So it shows quite a variety in how the MDTs are made up. We have a lot of fetal medicine midwives with doctors, which is great, but there was some lack with sonographers being involved and the wider team. Some patients were sometimes involved, but just the variance within that just wasn't very equitable to provide a service where we felt confident that these teams were providing the MDT and discussing cases and having that feedback mechanism about cases and things that they'd learned. And this is just to show the microarrays and the R21s that have been sent. This is what was reported by the units themselves. I only received the Great Ormond Street information about the R21s yesterday, and the slide hasn't been updated, so unfortunately I can't show you that. But it did show that there was some issues around reporting, and when they were feeding back with these questionnaires, they did say that they were struggling to collect that data or find that data. It hadn't really been stored, or there's no sort of system about what should be stored and when. So that was interesting to sort of think about moving forward, how we do advise people to store that data so that we can look back on it. Interesting also there are some units there which aren't tertiary centres that were sending R21s. I did ask them about how they sent them, and actually some of the feedback was that they were sending them sequentially, so that just adds to the timeline. So again, that's thinking about training and probably looking at some bespoke training for them in the future. This is a map just to show where the different units send their genetic referrals, and then the big arrow, the big purple arrow, is to show that everybody sends their R21s to Great Ormond Street, and that's where they're processed and fed back. And this is just some training needs that were identified on the questionnaire. We did have a group of midwives that were mostly sending them back to me, so it is midwife heavy on the feedback. But saying that they didn't feel that there was easy access to training materials and updates from refreshers. Some didn't have any R21 training at all. So that's interesting, but just thinking about, we do have lots of resources. I know there's lots of resources out there that they can use, so it's about how to make that easily available for when they can do it in their busy working environments. All of the hospitals cited ARC, so that's Antenatal Results and Choices, which is a charity that supports women and professionals working through the fetal medicine abnormality pathway, and they're an amazing resource. They support us to be able to provide counselling services and support families through that journey in the best way possible by bringing that sort of patient experience back to us. And so thinking about whether or not we can engage with them to create some resources around the R21 to be able to feed back within that mechanism, because they have quite good attendance for training. Here we were talking about patient support and feedback. So we wanted to know whether units do have a mechanism for getting feedback from patients if they've been through their fetal medicine service. Only one did have a specific fetal medicine questionnaire that they did use, and then a couple used the friends and families questionnaire, and then the rest either so they didn't have one or they didn't know. So that's an area that we're going to work on, and we'll talk about that a little bit later. And then in terms of providing emotional support for families and psychological support, there's a lot of variance within this as well, and there's some areas of excellent practice where the families are able to access psychological support from psychologists, but a lot of it falls on the fetal medicine or screening midwife's shoulders. We're not trained counsellors. We do our best, but again, we need to be able to have access to timely referrals to psychologists when families are struggling with the complexities that they face if their child has a condition or suspected to have a condition. Genetics is also closely followed, and charities again like ARC and Petals as well. So got a list here of things that we're starting to work through to try and improve the equity of access to the R21 and the way it's run throughout the region. So first of all, we want to develop a fetal medicine network in the East region. There isn't one currently, and that's going to hopefully tick a lot of the boxes about how we're going to engage everybody that needs to be engaged, disseminate information, education, and have some feedback from the units. We want to sort of standardise some of the MDT practice, so develop some best practice guidelines and share that with the services. Consider KPIs around the R21 and when it's being sent and delivered, and some sort of way of keeping record of that so that we standardise that, so that if we want to ask for figures again, people go, yeah, we've got them for you, there you go, and not have this kind of issue again. And look at the district general hospitals that are sending 21s to make sure that they're sending them in the right way, that they've got a clear pathway if they're doing that, and perhaps be able to link them better with the tertiary centre if the women are not going there because they can't get there or they don't want to, they decline a referral, but they still need to send the sample. Just sort of working through that process to make it streamlined and more efficient. We want to bring those quick reference decision tools and things that are there, so your GE notes and your Q genome resources that are coming out, and we want to make it where so clinicians can use them in the clinics to help them make their decisions. And then the education I've kind of already touched on, but it's a massive thing, but there are lots of resources, and we're going to also be releasing some new resources as well. We want to develop equitable patient feedback resources, so that's going to be multilingual stuff as well as easy read guides for the R21, because at the moment there doesn't appear to be anything. If something comes out, then we will just use that, but if not, I want something to be in place pretty soon. And then also want to engage with the patient public voice to be able to generate that feedback tool that we talked about, so that the fetal medicine units in the region can use the same feedback mechanism to get that feedback from patients, so that can then inform what we're doing, because we don't actually know what we're doing is what the patients want, because we're not asking them. We just think we know what they want. Okay, and then the bigger picture is that we will at the end present a business case about to make sure that what we're kind of suggesting and what we put in place is going to be sustainable, so that this can carry on as the fetal medicine service sort of develops, and as more R21 tests and criteria for inclusion come on board, that's just going to be rolled out and just taken on. And then hopefully we will have some best practice to help and show a model of how to involve if there any more genomic tests come into the antenatal care pathways. Okay? And that's us.
So my name's Kate Downs, and I'm a bit rubbish at not moving around too much, so I'll try and be quick. We've got lunch coming. So I'm going to tell you a little bit today about how we're transforming our diagnostic pathways for familial hypercholesterolemia. So the long-term plan in 2019 was published, and in this long-term plan, which is kind of a call to arms for our NHS, there are two sections which describe familial hypercholesterolemia. And these highlight the number of patients in the UK, in England, that are affected by FH, And they also highlight the fact that we don't know, most of the people who are affected by FH don't know that they're affected by FH. And in 2019, there was a pretty ambitious plan set that we would reach a number of 25% of those patients having that diagnosis, but within 5 years, within the next 5 years, through the Genomics program. So we're nearly at that 5 years now. I don't think we're quite at that 25%, but I also know that there's been a huge amount of work within the East that I'm going to tell you about, but across the country to try and increase this diagnostic rate. So the impact of familial hypercholesterolemia is really great. It's a really common disorder, so 1 in 250 of us will have a genetic variant that causes us to have a dysregulation of our lipids within our bodies, and that causes us to have an increased lipid level, early onset of coronary artery disease, and that can cause heart attacks and people to die. So the numbers are really quite stark, and by the age of 50 in men, 50% of these patients will have coronary artery disease. And half of those patients will die of an MI event, of a heart attack. In women, the numbers are a little bit better. So by the age of 60, 30% of those individuals with familial hypercholesterolemia will have coronary artery disease. And the same again, about half of those will die from a heart attack. Thank goodness we've got some great treatments. We've got statins. We all know about statins. And we've got dietary treatments for FH. And if you treat patients early with these treatments, then you really reduce the rate of coronary artery disease and that risk of having a premature death in these patients. So if you go to the doctors and have a cholesterol test, then the doctor knows that you've got a high level of cholesterol. They can start to treat you immediately, give you some advice on smoking, drinking, and your diet. And actually, doing a genetic test doesn't really mean much for you as an individual person. But by identifying the genetic variant in that patient, you can start to do cascade testing in their family members to identify more individuals. So familial hypercholesterolemia is a dominant disorder. If you're a patient, then you've got a 50% chance of passing that on to your offspring. And so within a family unit, 50% of the individuals within that family unit will have hypercholesterolemia. In the Genomic Medicine Service, all of our GLHs, including the East GLH, now provide diagnostic testing for familial hypercholesterolemia. We do this using a next-generation sequencing test to look for genetic variants in 5 genes that we know are associated with this disease. When we've found that patient, and we're trying to then see whether or not the members of the same family are also affected, then we can do what we call a cascade test, and we can test for just the presence or absence of that genetic variant that's within that family. And that's a bit of an easier test. So within the East, we've done some transformation work. I'm going to describe 3 projects today. There are differences in scale, but I hope that they give you a flavour of the hard work that we've all been doing around familial hypercholesterolemia. So the first is around our information zone. So a few of us have got together and really tried to generate a set of web pages and documents that provide all healthcare professionals with the opportunity to become confident and competent at ordering genetic testing for familial hypercholesterolemia. If we're going to get to that 25% and move forward and get to 100%, then we need everybody who can to be thinking about ordering genetic testing. So what we've produced is 3 documents and these 2 web pages, and they're published now on our website. The FH pathway is a flowchart, a clinical pathway that hopefully people can print out, stick on their wall, or go to as a reference when they see a patient with a high cholesterol level and they're thinking, well, perhaps this could be familial hypercholesterolemia. We consulted widely on that FH pathway, and that came up with a lot of questions. And so we've put a lot of the answers and those questions, a lot of the questions and those answers to those questions in a frequently asked question document. And then we've also tried to simplify the test ordering process for FH. Now, this is still a piece of paper form, but you can edit it on a computer. And the point in this form is to provide an easy way that a healthcare professional can select between ordering a diagnostic test or a cascade test for FH. We've also aware that the consent discussion around doing an FH test in a patient is very different from doing a whole genome sequence. And so what we've done is we tried to distill the important implications for that patient and that family in 4 sentences, and we've added those sentences to this test order form. So actually, that clinician, that healthcare professional who's ordering that test can use that whole test order form to order that test, but also have to use those sentences as a guide to have that consent conversation with the patient. So that's the first project that we've done, and we've rolled this out. We're aware that this may be used by some GPs, hopefully, but others maybe not. We're aware that we're just trying to increase visibility of FH testing and making it easier for everybody to order testing. The second project that I want to talk about is the largest project that we've been doing, and this has been a joint effort from the GMSA, the GLH, an academic group in Nottingham, and a company called Eclipse that live in Norwich. So the academic group in Nottingham published several years ago a logarithm that helps to identify patients that have a high likelihood of having FH. And they're using lipid data and a bit of family history data and a bit of phenotype data to do that. So you can do that within, a computer system and pull out numbers of people who have high risk and low risk, but that's not much use to us as delivering healthcare. The Eclipse database, database is a GP record database. So GPs use, one of probably 4 or 5 IT systems across the country. And so it's very easy to pull data out of those GP records. And we can use, if you combine these records with that logarithm, then you can start to stratify patients within this tool that we've generated to identify those individuals that have a high risk of having, a high likelihood of having FH. So we've got this tool, we're calling it the FAMCAT Eclipse FH Hub tool. Maybe we need a fancier name for it. So this tool can provide a list of patients, and this is still anonymized. And then we have a system within the Eclipse data system as well, where patients can be contacted directly. So this is still anonymous. Nobody's phoning them up and saying, we think you've got FH, do you want an appointment? They would receive an email or a text to say, would you like to log on to this website and find out more information? And so the patient would log onto the website, provide some information about their family history, perhaps lipid profile, and they would consent for contact. And the patient engagement team would then phone that patient and arrange an appointment with our FH Hub. So the FH Hub is a virtual entity, which currently is a lady called Shalina, a specialist nurse called Shalina, and our FH Hub is in Norfolk and Norwich, and it's serving the population of Norfolk and Waveney and some GP practices within that population. So our specialist nurse would have a conversation with that patient. They would go through the results of that questionnaire, and they would arrange genetic testing, talk about treatments, feedback information about diet, And hopefully once genetic results are come back, then they would start to arrange cascade testing for family members. So we've gone from an academic algorithm, a system that allows you to interrogate GP records, to being able to use that information to stratify patients, contact them, and have those conversations around genetic testing with them. So we've got one pilot site at the moment, as I said. We've got one wonderful specialist nurse called Shalina. But I think that this is a model that we've tried to, this is a pilot project that we've set up because we think that this is the model of how we're going to deliver FH testing in the future. So the final project is on a very different scale. It's a very small project in the Cambridge lab, and one of our trainees is doing this project. One of the barriers to genomic testing is around the phlebotomy clinic. So a patient has their appointment and they would like to have genetic testing, but they still have to go to a phlebotomy clinic and have blood drawn for that sample to then be sent to the lab and be processed. So at the moment, we're hearing very different things about phlebotomy clinics in our region, but it's a resource that's precious, and we know that people are waiting quite a long time sometimes for their phlebotomy appointment. So just to quickly tell you that, so once the sample would come to the lab, we'd sequence it, and then we'd analyse that data and report that. And what our trainee is doing is trying to see whether or not we can use DNA extracted from saliva samples to do that diagnostic testing. So this is something that's, we do use DNA extracted from saliva in the NHS for genetic testing, but we haven't yet in Cambridge used the saliva DNA for diagnostic testing using our next generation sequencing panel. So this is a project that's ongoing. I hope in a few months, if this is successful, and we're all crossing our fingers, then we can start to introduce home sampling to this pathway to then, mean that we're not having to use those precious phlebotomy services when we can do home sampling. And hopefully it will be a much more equitable way for patients to contact their family members for cascade testing by just sending a pack with a saliva sampling kit to them. So I guess just to finish before lunch, I think I've told you about 3 projects. One around how we're providing information for mainstreaming genomic testing for FH. The second around case finding, which is our transformation GMSA project. And the third around a small project that we're doing around sampling, which is hopefully going to impact significantly on that pathway and how we can get samples from a patient to the lab. So back to that NHS long-term plan. I think we're nearly getting towards our 25%, but I definitely want to tell you that we're not going to stop there. We're definitely going to work towards that 100% moving forward. And we will do that by identifying those key patients and then doing that cascade testing on those family members. So there's lots of people to thank, especially our FH specialist nurse in Norfolk and Norwich, Shalina, and my trainee in Cambridge that's also called Kate. Thank you.
Thank you. So we've been hearing a lot about various transformation projects, really powerful patient stories, and what's happening in the region about mainstreaming and so on. I just wanted to sort of bring it back a little bit to the lab and what the lab is doing about supporting some of these initiatives, but also some other projects. And Kate already touched on various projects that are happening, say around saliva testing, to be able to get more patient samples into the lab and so on. But we know that the regional genetic laboratories always supported a number of academic projects and clinical trials and so on. And really with the creation of the GLH's networks and loss of some of the smaller labs, there is clearly been a loss of some of this capacity and capability around providing testing to support smaller scale academic research and so on, as we've been having to really focus on delivering the National Genomic Test Directory. So just to put things into context, obviously we are The GLH is made up of 3 laboratories, the lead laboratory based in Cambridge, and then the local laboratories in Leicester and Nottingham. And when the GLHs were initially commissioned, and the Cambridge University Hospital's genetic laboratory was awarded to be the lead laboratory for the East region, there had to be a lot of transformation of that laboratory space and how it was set up, and a lot of consolidation of services, introduction of new technology, and so on. So really to deliver the high throughput, high scale testing that we need to deliver to open up the genomic testing for all the patients. So I just put a few milestones here. This is for the Cambridge laboratory. There's obviously been a lot of developments going on at the same time in Leicester and Nottingham laboratories as well. Important thing to note is that we've been doing a lot of this transformation, including some building works, through COVID and never stopping to offer the service. So it's been a really huge achievement for the laboratory to keep going with the services normal whilst introducing so many new tests. And technologies and expertise, obviously, then both the genomic technologists and clinical scientists had to adopt to be able to deliver all these new genomic tests that we are now offering. And obviously, still continuing with service developments, there's still a lot of work to do, both in the assays and technologies, but obviously turnaround times and so on. These are just some nice pictures I've got from the laboratory, and just wanted to highlight that the top center, which is a Genexus platform, which delivers the targeted, fast cancer tests, those 2 machines are now also available in Leicester and Nottingham. So even though the NHS England sort of expected us to do a lot of cancer testing, or all of the cancer testing through next generation sequencing panels, in Cambridge laboratory, actually, to make sure that we open up the testing and meet the turnaround times, we also set these up now in Leicester and Nottingham as well. So, and obviously, huge credit to those laboratories as well. So all this work is going on just to deliver the test directory. And it's a very prescribed sort of commissioning model in terms of what we need to deliver. And NHS England every year sets out these guidance documents for us, for every GLH, and tells us exactly how they're going to commission our service and what we need to deliver, when, and so on. So whilst that is the focus, they do also mention research, and they do mention evolving the service. And of course, part of their research is a number of these transformation projects that we've been hearing about today, but it's also about ensuring that we deliver cancer testing in a way that patients can be stratified into clinical trials and so on. And to evolve the service like that presents itself a lot of the challenges, because we're not set up as an R&D lab, we're set up as a diagnostic lab, but we obviously have to do all these additional things on the side. So just a few pulled out a few things that sort of came to mind to me. We do have, we are like everywhere in the NHS, the laboratories are struggling to attract the staff and to retain the staff and so on. So we're constantly delivering the service with a shortage of staff. So where do you then find the staff to do the additional developmental work? We also have clinical scientists who are very much focused on providing the diagnosis. So if they're to be involved in some research, they're then having to constantly switch the 2 mindsets as well, which is, quite a big ask and a skill in its own right. It's not clear nationally where exactly the line between the clinical and research sits. We are now performing a lot of our diagnostic testing on exome and genome, a sort of sequencing type of tests. And often these data but previously this was done as part of research. And all of this data would be sitting in the research environment with fully consented individuals. So how do we then open up their data now that's come through the diagnostic service? And whole genome sequencing is a minority of the tests we do. Actually, we do far more large cancer panels tests, and all the data sits in the GLH, in all individual GLHs, and all of our data is in a cloud. So I'll just briefly mention how we open up that kind of local model that we're trying to work on. And then, yes, of course, the space, the people, and so on. And even though NHS England says in this planning guidance that we have to support research, it's actually not quite clear how they're going to commission that, how they're going to pay for that activity, as it says. So where does that funding then come from? And one thing that we've been all pushing at all the GLH is saying, well, if we are to support clinical trials and other research activities, it would be really good to have a standardized national tariff. Now, something does exist called NIHR tariff, but even the latest version of it is not fit for purpose because it does not reflect at all the type of genomic activities that are happening in the country. It's very outdated, based on kind of single gene tests and things like that, which we very rarely do nowadays. So, but, you know, all of these constraints, we are still looking for opportunities and looking how we can do this. So on the website, the research pages are very, very brief, and it's my to-do list to try and revamp that a little bit. So open to any suggestions, please email me if you have any website suggestions, but at least there is a research application form. So we do ask when people contact us about, oh, I have this study going, you know, I've got about 200 patients applying to do this, could you do this testing on them? Unfortunately, we do have to turn a lot of people away because we just do not have resources, but also sometimes we are able to, and I'll just briefly mention a few studies. So, you know, at least it's a start, there is a formal application, and then that means we can capture these applications and we can actually evidence that at a kind of higher level, saying, look, you know, there is all this research potential that could be happening through the GLH network, but it's not because, you know, we're still trying to build the resource. And I just put a few examples, and these are just some of the examples of some of the studies that we are sort of managing to support. So in the rare disease, and Kate Downs really leads on this and is really championing trying to implement some of these studies in our in a way that it does not disrupt services. We're looking at opportunities where we can support a study that fits in as much as possible within a business as usual. And because we do a large or small NGS panel testing, some of these studies look at specific variants and added value of those variants. So for example, polygenic risk scores. So because those researchers approached us early enough at the design stage of our assay and said that, oh, look, we want to do this clinical study and actually use these PRS scores in the clinic, so therefore we do need these to be generated in a clinically accredited lab. We can't just go to a research lab and ask them to do this. So it has to be clinically accredited, so it has to be the GLH lab. We've added the targets for those SNPs at kind of no extra cost, additional cost to us, and are sending that data through the bioinformatics team back to the research team. And this is one of the studies that will be subject of the talk straight after mine. But we also support studies with our clinical scientists in terms of their expertise and, you know, helping interpret some of the data and so on. We also obviously support a number of clinical trials, and again, comes back to this who accounts for that in terms of where is the funding for that, because it's not just about including additional variants in our reports. For some of these trials, we're actually having to upload certain data into a certain portal that the trials team is using that is not a standard of care test. It's just, you know, the sort of a trial design and so on. And it's a little bit of extra time, but it all adds up. So, as I say, we are sort of trying to support as much as possible, but it's definitely looking for better ways to standardize things nationally and having those national conversations. How do we actually really support and fund research and development activities that can then really bring this innovation within the GLHs, more as a kind of business as usual, embedding that research, which is, you know, going beyond the individual transformation projects that last 1 or 2 years. This is more about a longer term sustainable resourcing and thinking of, you know, whatever funding model is required. So, as I mentioned, one of the issues we have is about the space and staff, both in the technical team and the scientific team. But once we generate the data are there. So actually a number of studies we're supporting now is actually bringing the researchers to the data. Now, obviously, these are not always consent individuals. However, with the NHS data, we can use anonymized data to develop service. So, for example, all of our NGS data in the cloud that we use are anonymized samples. There is no individual information there. So if we wanted to test a new analytical pipeline, those researchers can come to data and implement those pipelines directly in our NHS data store, so that whatever they develop stays within the NHS, rather than a lot of these analytical advances being developed in research and then taking actually a long time to transfer into the data sort of structures that exist in the NHS. And so we do have a number of projects which are sort of looking to bring the researchers to the data, but as I said, we don't have necessarily standardized governance and these clear lines. So these are, again, some of the things that I'm working on with our R&D teams and with the national teams around the governance and thinking, how do we standardize this? So I think that was the end from me. And I'm just going to pass over to Nichola to describe one specific study that we're supporting through the GLH.
Thank you very much. Let me just make sure this works. It does. So my name is Nichola. I'm a research genetic counsellor. I'm also the project coordinator on this project. It's called Precision HBOC. And also to prolong my student discount as long as I can, I've also taken on a PhD quite recently. So our project, which Hana said, has tied in really nicely with the GLH, the work that they do. And I think being able to tie research with clinical work and being able to integrate that into clinical work is really important. So our project is stratifying risk. Sorry, it's not coming up on my screen there. Stratifying risk for early detection of hereditary breast and ovarian cancer, or precision HBOC. So I'm going to briefly go through the who, the what, the why, the when, the where, how this project is going to be implemented and what we've been doing so far. So right now we are currently we've started in 3 site projects, so ourselves in Cambridge, Manchester, and as Stanford in the US as well. But because recruitment hasn't been quite as good as we had hoped it would be, we've started to extend that out into other sites as well. We're under the ACE umbrella, so under CR UK, the Alliance for Cancer Early Detection. So our aim is to recruit 600 patients over these 3 sites, but as I'll say in a little while, we're going to increase those into a couple more sites. Thank you. So ourselves in Cambridge, we have a catchment area of about 3 million. Around 62 women a year come in for predictive testing, and they test positive for predictive testing for BRCA1, BRCA2, PALB2, CHEK2, and ATM. And they're the 5 genes that we're interested in looking at in this study. So as I said, recruitment was not quite as much as we would like it to be in this early stages of the study, so we have been taking on extra sites. So we started, as I said, in Manchester and Cambridge. We also have Leicester and Southampton now recruiting for us, and we've had our first patient, with the thanks of Vicki Kiesel, we've had our first patient be recruited through Leicester. We're also very close to starting recruiting in St George's and in Guy's and St Thomas, but we're also taking on Nottingham, Leeds, Oxford, Birmingham, Liverpool. Gosh, I think that's it. It's a lot of work for us to do. So hopefully with all of these sites now included, our catchment area will go up to 45 million, and we are praying that that is enough to get our 600 patients in this study. So why are we doing this project? For women who come in for predictive testing for BRCA1, PALB2, CHEK2, or BRCA1, BRCA2, PALB2, CHEK2, and ATM, they're given the same broad cancer risk estimates. So for example, a woman coming in for predictive testing for PALB2 pathogenic variant, she might be given a 44 to 63 lifetime risk of breast cancer. And we wonder how useful that is for women undergoing that testing, of having such a broad risk. And if you ask somebody who is at 44% risk of breast cancer or 63% risk of breast cancer, they might make two very different choices in terms of their risk management options. So we wondered, does a personalised risk estimate mean that these women make better choices in terms of how they manage their risk in terms of their breast cancer? So under that premise of personalised risk equals better choice, we're looking at the acceptability, the feasibility, the effectiveness and the economic benefit of including personalised risk, including polygenic risk score, to these women undergoing this predictive testing. So we're looking at the uptake of the study and of personalised risk itself. Does it change their perception in terms of their cancer risk? Do they retain knowledge better now that they have this personalised risk? And ultimately, what risk management options do they take? Are they very different to what they thought they might take in the first place? And that's both undertaken and planned, so in the future. So how are we doing this? That might be, I'm hoping you can see that, but it's just a very quick overview of how we're running the study and how we've set it up. So women are referred into the clinical genetics department. That is when we pick them up. So they're referred for predictive testing for one of these 5 genes. So there's already a mutation identified within the family. They're coming in, as somebody was talking about, cascade testing, so seeing if they're at risk as well. We send them an information pack on the study, see if they would like to take part. They can decline to take part, obviously, but if they do opt in, then we will consent them. We'll send them a baseline questionnaire. They'll still undergo normal clinical testing through the clinical genetics department. Results are given in the conventional way through the genetic counsellors or the consultants in the genetic team. If they do not have the mutation, then no further action is taken in terms of our project. But if they do have the mutation that's present in the family, we will then randomise them into either control, so they receive the standard risk estimate that they would have should they have remained in kind of normal clinical care, or they get a personalised risk. So we'll include lots of different factors, including a clinical grade polygenic risk score panel to calculate this personalised risk score for them. We'll then follow them up with a 1, 3 and 12-month questionnaire, following them in terms of what risk management options they've taken, how they are and how their result is with them, things like that. So how are we doing this? It's a fully online study, so we take consent and the baseline questionnaires are all online, and then the follow-up questionnaires are all online as well. It's done by the Qualtrics survey platform. In the baseline questionnaires, there's questions like, how likely are you to get breast cancer in the next 10 years, both in Likert and a linear scale? How worried are you about getting breast cancer in the next 10 years? How worried are you about getting breast cancer in your lifetime? Questions asking how they are in uncertainty and unforeseen events, ranging from not at all like me to entirely like me. So gauging how they are in uncertainty and waiting for those results. Asking how well informed they are about the risks. So this is obviously before they see a healthcare professional, how informed they are, how have they found out that information, if they are either kind of informed or very well informed. Have they thought about what options they might take if they do inherit the mutation? And what options they might consider. So say, for example, this is surgical options to manage breast and ovarian cancer. So have they thought about that option? Would they consider that option? And if yes, when would they consider that option? And if they consider it in the next not in the next 6 months, but a bit further on from that, what are the considerations into why they're making those choices? So things like want to start a family, want to breastfeed. We've had one woman reply that she wants to complete her goal of running 100 marathons, which is absolutely incredible. So all these different influencing factors that go into why women make the decisions at the time point that feels most relevant for them and right for them. Within this baseline questionnaire, we're also taking all the CAN risk data, so how their height and weight for BMI, alcohol consumption. And then we are taking all of those risk factors. So we're taking their pathogenic variant, so the mutation in BRCA1 to PALB2, CHEK2 and ATM. their family history information, hormonal factors, lifestyle factors, and PRS. So we're putting those all into the CanRisk tool to get a really personalised risk estimate for that woman. Right now, these are a little bit outdated figures, but we are slowly building up the numbers of patients going through the pipeline of this study, hopefully going to build up a really great number of patients and reach that goal of 600 patients. I think that's all that I have, so thank you very much.
Hi, so I'm Vicki Carr, lead nurse for the GMSA, and this is Jo.
Jo Hargrave, lead midwife.
And we thought in this session we wanted to talk to you about the work we've undertaken in year one, what we've actually done to support our nursing and midwifery workforce, and then really look ahead to the next 12 to 24 months. So to begin, we thought it'd be good to look at when we started as a team. So even though the GMSA started early 9 months before we came into post, we essentially had 3 months to complete some work within that first year. So we worked very hard to complete the assignee tool. That was our main priority at that time. I'm going to come on to say a bit more about that in a moment. But the really good thing about that piece of work was the networking, and it meant that we had to go and speak to different professionals in all the different organisations, or as many as we could in the time available to us, to find out about genomics, maturity and nursing and midwifery at that time. A few other things to pick out from this timeline. We were starting the Genomics Links network that we've developed in our region, where we meet bi-monthly with senior nurses from as many of the 29 trusts that we can in our region. And a monthly nursing midwifery oversight group, which is part of the governance structure, and we feed into the GMSA management board. We were then working hard to the nursing and midwifery national transformation projects, and I'm going to come more to say a bit more about that. We launched the NICU PQ project, nursing part of that in August, and I'm also going to say a bit more about that later. And we ran a conference in November in Leicester, and then very recently Jo has come to join the team, so very pleased to have Jo on board. So a bit more about the assignee. It's the assessment of the strategic integration of nursing in genomics, and the E is for England. It's a global tool, and then it's been adapted for use in the NHS. And so we completed 3 different tools, one for monogenic diabetes, as that was one of our projects at the time, and Lynch syndrome, and then nursing and midwifery. And this slide relates to the nursing and midwifery assignee. So it is a self-assessment tool, and we had to kind of do speed dating, essentially, with all the different stakeholders in our area to try and get a typical picture. And we found that typically we were at the pre-contemplation stage for nursing midwifery, which probably isn't a surprise to anybody, although we did highlight and identify areas of exemplar practice where they were much more mature than others, but we really wanted the typical picture. Okay, so from that we had a number of actions. So what have we done with that information? We've done a lot of building capability through education and awareness for nursing midwifery at every stage of practice and in each setting. We recognise that whilst there are nurses and midwives with master's level study in genomics, most nurses typically there isn't that level of maturity or literacy out there. And with nursing midwifery combined making up 25% of the NHS workforce, there's a lot of work for us to do. And we have the most touch points with patients as well, so we're more likely to see patients at multiple points throughout their pathway of care, particularly for nurses and midwives working in CNS or CMS roles. So yeah, we've helped nurses to access master's level study, we've delivered education, and we've helped people to know about the existing resources, of which there are many, and I think this has been touched on a few times today already, but more than any other section of the workforce, even though there are multiple resources out there for education, nurses don't know about them, they're just not aware at all, and so we've had to do a lot of work with how just drawing them of their attention, and then thinking about what we do with that information next. So to think about how nursing and midwifery actually fits into some of the projects that we're working on, we've just picked out a few where there are nurses working on specific projects here. So cystic renal disease, I'm going to talk about a bit more. We've already heard about familial hypercholesteraemia and Shalina's role there, and Lynch syndrome. We have Melissa, who's in the audience here today as well. So high level of nursing involvement for mainstreaming for particular patient pathways. And we have an EQPQ nurse-led arm of the service, which I'm going to say more about shortly. Okay, so some of the challenges, just to pick up on a few. As I've said, building genomics literacy for nursing and midwifery, variations in service design and delivery, massive changes. So even where there are services with a high amount of specialist nursing input, there's a lot of variation and different resourcing, different parts of the pathway that nurses in particular might deliver diagnostics or diagnostics and treatment, and it seems to vary greatly. Operational pressures, we can't deny, have impacted us and our ability to engage with nurses and midwives, certainly in this last 18 months, and capacity of the clinicians. I think for nursing, the perception of relevance to their roles has been something that we've had to tackle as well, and had to sort of start to build that understanding. And one of the ways that we've done that is using case studies, as that's recognised as a really good way to bring genomics to life for nurses. But yes, definitely has been impacted by industrial action and the winter pressures that we're all feeling, I should say. So I'm just going to hand over to Jo to talk a bit about midwifery and some examples of mainstreaming.
Yes, thank you for letting me come and join you, Vicki, for this. I've only been in post a couple of weeks, but I thought it was really important to sort of share the midwifery side of things as well. So what I wanted to do was just talk very briefly about where mainstreaming is already part of midwifery, and that's in non-invasive prenatal testing. And that was rolled out in June 2021 as an evaluative rollout to look to see where we could use non-invasive prenatal testing. And so for those of you who don't work in midwifery, women are offered screening from about 12 weeks of pregnancy to look at their chance of having a baby with either Fetal's, Edwards or Down syndrome. They have a first trimester screening. If that comes back with a higher chance result where it indicates that there may be a more chance of the baby having the condition, they would be offered in the past an invasive test or no further testing. So that meant a high proportion of women would be attending the fetal medicine units for a diagnostic test to find out a yes or no answer. And what NIPT does is actually looks at small fragments of cell-free DNA that are shed from the placenta and circulate in the maternal blood. We can take a sample and analyse with really high accuracy whether that baby is more or less likely to have the condition. And what this has meant is there's been a really high reduction in the number of women coming to those fetal medicine units, which was really beneficial for patients, really, not having to travel miles on end to see those fetal medicine specialists. But also for the fetal medicine specialists themselves, actually being able to have time with other patients that are coming with anomalies seen on scan. It's also helped patients with their kind of decision making as well when it comes to those who want to continue a pregnancy and don't want that risk of having an invasive test. It's really helped to support them along the pregnancy pathway. There are challenges with it. It is an evaluative rollout, so there's lots of questions around the statistics within that higher chance population. And also, who else may benefit from having NIPT? So that's kind of one of the mainstreaming. Something else that's going to be coming soon, and I will leave it to John and Kate in the back if you want to hear more about it, they're waving, is the Newborn Genomes Project, which is a research project to look to see how and if we can have the benefits of sequencing and analysing the newborn's genome. So yes, lots of discussion around that, I would say, at the moment, but at some point it will be a pilot in a number of trusts across the UK, and midwives will have touch points and be responsible for sharing that information, having those discussions and potentially being involved in the results as well. I don't need to talk about this project because Kasia and Lauren did it so eloquently, but again, it just highlighted the touch points where midwives are involved at every level and how important they are to that patient care. So seeing what work has been done so far is fantastic, and I look forward to working with them both in the future. Now, finally, Vicki asked me for my engagement strategy for midwifery last week, and so this is just what is in my head. This is me now mapping, scoping. Basically, the bits I enjoy is having those conversations with all the multi-professional teams to know what's going on, where the gaps are, and also with our patient group. It's so important, especially hearing from the speakers earlier about moments where midwives have made an impact in their care. So yes, I'll be talking to lots of you in the future, reflecting on what you're saying, and hopefully that we can bring more of the conversation to the workforce to ultimately improve our services and that equity of access. And then finally, hopefully get lots more opportunities for our specialist nurses and midwives to work together in the area of genomics. And I'll pass back to Vicki. Thank you.
So just to say a bit more about some of the projects where we have had direct nursing involvement, because I thought it was important to sort of hone in and tease out what that's meant for nursing and what we've learned from that so far. So I know the next talk is about the NICU-PICU overarching project, so I'm not going to talk about that. It's really just to sort of talk about nursing. So the project that's going to be the next talk has got a nursing arm, which is based in Cambridge. So a small nurse-led service. One of my colleagues is in the audience today, and they've, for R14, developed a service for rapid exome sequencing for children in NICU and PICU, and for other tests in the Child Development Centre at Addenbrooke's. And their role is largely around those consent conversations and sampling and tracking sampling pathways. We've got the figures here. This is since the service started and went live in November. It's not for financial year or a calendar year, but so 19 R14 patients, 38 others, and we can see here they're mostly neuro, but one has been renal and one respiratory immunology, and a total of 57 patients. We've found, really they've been trailblazers in this new role for nursing, and the template of the education that we put in place and the induction period, and we've just evaluated what worked and what maybe we might have had less of and what we needed more of, because there was no blueprint. So we had a 3-month induction period during which time the service was being built, being developed. We mapped the current pathways for inpatients in NICU and PICU, and then we mapped what it could look like with the genomic clinical nurse specialist as part of that, and did some stakeholder engagement at the time as well. Some of the challenges: it is a small service, we only have 2 nurses, they make up 1.2, so obviously there's some resilience in the service, but not a huge amount. There's lots of lone working. And we have found that patients are very quickly moving out of critical care areas, because, as we all know, as soon as somebody is wardable or can be repatriated to their own trust, that's going to happen pretty quickly. And then there was the dilemma: do we still provide that service to that person that's been referred or not? And we, in most, have. have done so. So we've found that nurses have really good understanding of how systems work in the trust, and they have got really good relationships with between professional groups. They've needed to build relationships with the professionals working in clinical genomics, so those relationships weren't there. Lots of transferable learning. We've been able to share the education package and the role design with other, like the children, teenager and young adult cancer ODN for their CNS that's recently going to be coming into post. And we've also, as for part of the pilot, put clinical supervision in place for the two nurses, so monthly clinical supervision with an external provider. And that's been very interesting. And some of the feedback is it does give that time to talk through difficult cases and discuss how to approach potentially difficult or challenging situations. And that's not something that nurses would ordinarily access. Next steps, commissioning conversations. So Dick and I are trying to get the right people in the room to find out who is going to finance this essentially beyond the 12 months. And then we've been accepted to go and speak at the RCN International Nursing Conference in Manchester in September to share our learning. And then our project that I mentioned earlier that we've been leading on as part of the National Nurse Midwifery Transformation Project is cystic renal disease. And we started off by sending out a survey to all professionals working in renal services really in the East, but also in other sites across England. So a mix of specialities, and the idea was to map the patient pathway and identify the nursing touch points. So as well as the workshops that we ran for professionals, we did 2 patient focus groups where we spoke to a number of patients, and that was organised for us by the PKD charity. Our findings, our insights, are that the diagnostic part of the patient pathway is mainly medical. There are renal genetics clinics and referral pathways in most areas, but nurses really only feature for this pathway in the treatment setting. In fact, most patients, or all patients, said to us they hadn't met a nurse until they either needed dialysis or they had a transplant, and then they had excellent care from a nursing professional as well as everybody else, but they just didn't encounter them before that point. Specialist nursing services for cystic renal disease are in 2 London hospitals or for some tolvaptan clinics across the country. And there are some sort of different interpretations of the test directory criteria because it does exclude, depending on how you interpret it, excludes asymptomatic cascade testing if PKD can be diagnosed by ultrasound scan and family history. So our outputs from this work, we're developing some patient stories to highlight, I think, for professionals, nurses particularly working in the field, renal G notes for primary care and secondary care, and we're looking to add in one for asymptomatic people who are at risk of cystic renal disease. We'll be working on a clinical pathway initiative and an infographic, and some recommendations for nursing roles in genomic testing in renal disease, and to think about patients in the surveillance part of a pathway, what support they might need and how nurses might contribute to delivery of this. So a quick summary of our engagement highlights over the last 18 months. I mentioned earlier the Nursing Midwifery Genomics Links Network. We've done a huge amount, and we've had 6 meetings. We haven't got representation from every single trust, but that is our next priority, to get a representative from each and ask that they prioritise their attendance so that they're in the room. We're only meeting every other month. We've started our lunch and learn sessions and newsletters, and that's going well. And numerous events and presentations with stakeholders across the region, as you can see here. So our next steps, developing our strategy, as you've heard from Joe and I, and I want to align that with the national strategy and work more closely with our counterparts in the other GMSAs to reduce that variation and share our insights from the projects that we're doing. More focused engagement with each of the trusts in our region. We're thinking visits to each of them in person and webinars. We want to offer them webinars, face-to-face sessions, and think as well about the nursing midwifery contribution to the projects for the genomic networks of excellence. And finally, the one thing I would like to pick out from here is about auditing higher education institutions, nursing and midwifery courses. So to do a piece of work where essentially we map the universities in our region, understand what courses they're delivering, and then work to build a network with them as well to look at undergraduate and postgraduate delivery of genomics for nursing and midwifery. That's it. Thank you.
Thanks very much. I'm going to talk to you about an East GMSA funded local project which is aiming to embed rapid diagnostic genetic testing for acutely unwell babies and children. As you can imagine, the intensive care setting presents a myriad of barriers in making a diagnosis due to the situation, the care situation, and the fact it's very difficult to examine children to see how they are normally. So some of the markers that would be, or features that would normally be available cannot be measured for those children. It's particularly the case with premature babies and really young children who might not have grown into a syndrome, for example. So why make a genetic diagnosis? It leads to accurate diagnosis and much better management for that child, as well as a number of additional advantages for that family in the longer term. Just to recap, the Rapid R14 whole genome sequencing service is for acutely unwell neonates and children who have features highly suggestive of a monogenetic condition, where achieving a genetic diagnosis could help with an immediate change in their management. So there's been an NHS funded service to offer this test since October 2019. And there's a couple of take-homes from this schema. The first thing is that it is a rapid test, and if you add up the days, you'll see that from thinking about a test and asking Exeter for a test, to actually delivery of results normally happens in around 3 weeks or under. The second take-home is that it's incredibly complex, and so it involves a high level of communication and coordination between different clinicians, the wards, genetics, scientists, parents, lots and lots of paperwork and blood samples, and several potential points of failure. It's an agnostic test. This means that it's a trio sequencing test comparing the DNA sequence of the baby or the child with the sequences of the two parents in a way that's not biased towards looking for particular panels of genes. What happens is the scientists look for patterns of variants that would indicate either a brand new change in the child or a recessive condition where the parents could be carriers and the child's inherited two genes, gene variants, or an X-linked condition, or perhaps uniparental disomy. And then what's really important is that the variant interpretation is done using the clinical phenotyping that has been provided by the clinicians. So this has to be of good quality. During the course of this project, the platform for the diagnosis has moved from whole exome sequencing, when you're looking at 1 to 2% of the genome, to whole genomic sequencing, where you're looking at the lot, the 3 billion nucleotides, and that went live in January this year. So the East GMSA project main aims have been to improve the delivery of the service across the region, and then to compare the use of different allied health professionals or registered nurses to help to arrange this very complex genetic testing, and also thinking about ways to support these families. As well as this, there's been an educational package delivered, and also we've been thinking, as Vicki just alluded to, a blueprint for how to think about this service in relation to delivering this for other services in future, and what training needs might be required. So this is our patch, and we started the project looking at within Nottingham and Cambridge as a joint bid, and then later on we brought in Leicester as well, so we're actually trialling 3 different ways of delivering this service. In phase 1, Nottingham proposed to use sort of 0.6 in total of a genetic counsellor, so it's a split role, and Cambridge have just been discussing that they've been using nurse specialists, again with overlap, to deliver this role, but also to support other paediatric genetic testing. In a later phase, we also have involved Leicester, who've used a 3rd model where they have a Band 5 genomic associate, or also called genomic practitioner, to support their consultants in organising the testing. I'm just going to show you the pathway for Nottingham, and a couple of points to make is that the call comes in from Nichola or Pico on the bat phone, and then there's a decision made about whether a child really does need examining or not. And about half of the children will need examining by a clinical geneticist in order to help to support whether R14 testing is indicated. And in that case, a rapid ward visit's organised, and then after that, the Exeter lab is contacted and a decision is made about the testing. From that point onwards, the genetic counsellor or the nurse can pick up the role of organising all of the consent, liaising with the ward and filling in the paperwork. I mentioned educational sessions, and these have been really important. So we've targeted the local PQ and NICU units, as well as using the East Paediatric Genetics Forum, as well, and general paediatric talks. And those have been used to cover a large range of practical issues around the testing, things to think about, such as has somebody had a transfusion, what samples to use, and also a large number of ethical issues which are associated with whole genome sequencing. So we think that that's worked quite well. I'm just going to look at a couple of figures here, but we've had a good, looking at a snapshot from the middle of last year at Nottingham, we've had a reasonable number of referrals both from the PQ and the NICU units in the region. So if I just break down a little bit of the data, we've got the strongest data for Nottingham, and that's because there are advantages and disadvantages we've found to both types of all the different setups. Nottingham was able to start early because we were using genetic counsellors in established roles. And so we started in September 2021. And you can see there's been a steady rise in the number of R14 trios completed. The last column is just for the first 3 months of 2023. Cambridge, as Vicki mentioned, had to really start from scratch. They needed job descriptions for nurses doing genetic testing, and so it took a lot longer to get going. But we can see that from 2022, there's been a good increase in the number of referrals, and also they're on track to improve that from the first quarter data of 23. We don't have all of the data from Leicester yet. They've just got going. I thought it'd be quite interesting to pop up the different roles and who can do what, and just from established job descriptions. And I'm not going to go through them in detail, but I do want to just say that while genetic counsellors can cover the majority of the role, including support for parents afterwards, there was the thought behind the Cambridge system was actually to be able to support other non-urgent genetic testing, and so that the nurse may have an advantage because of where they are actually physically in the hospital. So here are just some examples of some of the diagnoses that have been made in Nottingham, where there are potentially the chance of changing the management there and then for that child. So, for example, that osteopetrosis means there's a possibility of bone marrow transplantation. Some conditions thought to be epilepsy have not been, etc. And also we've picked up where it was highly beneficial to screen relatives for the SN5A, for example, gene variants, which is high risk of arrhythmia. I'm just going to focus in on Finke syndrome here, just to illustrate a sort of diagnostic odyssey in which Vaila Morrison really explained well when she was talking about her child, Ailey, earlier on. And this is about a 5-year-old boy who had a background of developmental delay and epilepsy, dystonia, and presented initially at 1 month of age with respiratory distress. Went on to have an absolute battery of investigations over the next 5 years. Had respiratory symptoms, hemolytic anemia, MRI anomalies found, but also some renal problems, and was referred to PQ at the age of around 5 for renal investigations. And over that time, just to point out as well, this child had had 5 lots of genetic investigations, so a huge gene panel for mitochondrial disorders in 2017, an epileptic encephalopathy panel in July 2017, a triome at Exeter, which didn't reveal anything. This was pre-R14. More genetic testing, 100,000 genomes, nothing found, 100,000 genomes, additional findings, nothing found. And then, just want to show that just after one of those sets of tests, the first publication was made of Finke syndrome. So it came after the Exeter trio exome had reported for the first time, so that gene was not known about. Over the next couple of years, a further few patients were actually described. We asked Exeter to re-evaluate the exome data, and they discovered that the child had 2 NHLRC2 variants, and that Finke syndrome actually fitted very well with the way that the child had presented over those years. But what I want to say is, what we'd like in future is that the first time that child presents, they get the WGS, and so that 5-year odyssey happens in 3 weeks' time. And wouldn't that be better? That's what we want it to be like in future. That's what we're aiming for by trying to embed this service right across the region. So I just wanted to look at the national picture and compare it with what's happening more locally. This is the almost live data from Exeter. It's a couple of weeks old. So since they started doing the national testing for R14 in 2019, they've now sequenced just under 3,090 trios. And out of that, they've made around 700 diagnoses. And 400 or so likely diagnoses, and then we've got some families where we've got variants of interest as well. So if we add all of these highly significant or quite significant diagnoses together, we're coming to a diagnostic yield of 36%. So just over a third of these children have got a genetic diagnosis. So if we focus in, I've just got the Nottingham data at the moment in more detail. If we focus in on the region covered by Nottingham, so Derby, Nottingham, Lincolnshire, Mansfield, this is where we are. So we've activated 194 trios since we started in 2019, the total, and we've had 49 diagnoses. And that actually equates to 26% pickup rate. We've got a number of variants of unknown significance for some of our families, and we've got a few that are still in the pipeline. Oh, looks like one of my slides has disappeared, so I'll just tell you what it is. Yes, it's gone. So what I want to say is that if we compare the pickup for Nottingham to the national picture, we've got a lower pickup, 26% versus 36%, but that's the side we want to be on because it means we are much less likely to be missing somebody. Okay. And the other thing to say is that if you take the national, the volume that we cover in Nottingham, we're about 4% of the population of England, but we're actually requesting 6% of the tests. But I think that might be meaning that they are under requesting throughout the rest of England rather than the other way. Where are we going in future? I've got 35 seconds. We're in the evaluation phase. We're doing cost-benefit analysis. We're doing a vertical audit. We're looking at how to embed services. We're looking at efficacy, equity of access, how many tests we're doing across. We're about to start a virtual board round to say, can we get those children on NICU, PICU, and to have genetic test earlier? Has it been thought about for those children? I've got 10 seconds. I'm going to thank everybody. Okay.
Good afternoon, everybody. The biggest challenge is coming up those stairs, not delivering this talk. Okay, I'm Anita Murphy. I'm a diabetes specialist nurse based in Kings Lynn, and I'm the regional genetic diabetes nurse lead for the East GMSA. I've been a genetic diabetes nurse for just over 10 years now. The aim of this session this afternoon is brief session I should add, is just to give you an overview of how we've embedded clinical champions within our area, and we're upskilling clinicians to make monogenic diabetes part of the routine pathway. Just for those of you that haven't come across monogenic diabetes, and sometimes it's known as MODI, I'm just giving you an overview of what that is, and it is a very brief overview. Like type 1 and type 2 diabetes, monogenic diabetes limits the body's ability to produce insulin, causing a rise in glucose levels, which causes quite significant damage to the major organs of the body system, and we get microvascular and macrovascular damage from this. Unfortunately, people with monogenic diabetes often present with the symptoms of type 1 and type 2, so they're misdiagnosed from the start. Unlike type 1 and type 2, which is multifactorial, monogenic is, as the name says, caused by a single gene fault. It's a faulty gene, depending on what gene we're looking at, but it's a faulty gene which each parent has a 50% chance of passing on to their children, unless it's a mitochondrial disease, and obviously every child will inherit from that parent. So it's quite significant for a clinician working in diabetes to understand the difference between monogenic diabetes and type 1 and type 2, because treatment differences are quite significant. Okay. So misdiagnosis of monogenic diabetes has been going on for many years. So I've been around for 10 years, and the Exeter team have been doing this for 20 plus years. Monogenic diabetes accounts for about 3.6% of the diabetic population diagnosed under the age of 30. However, we do diagnose people later in life as well. Unfortunately, 80% of people with monogenic diabetes are misdiagnosed. That number is getting better, but as I say, we're approximately back 2 years data, we were at 80%. And on average, it takes 12 years from diagnosis of diabetes to getting the right monogenic diagnosis. That's quite significant because we make significant treatment changes to patients depending on what gene variant we identify. And there's always been widespread variation in referrals. If you look at this map, you can see, obviously, the Exeter team down in the southwest have been on this for many, many years, which is why they have a significant pickup rate. But the rest of the UK and Scotland significantly as well. Scotland ran a trial 6 years ago where they were they were screening every newly diagnosed type 1 for monogenic diabetes. They had a significant pickup rate. But the rest of the UK, unfortunately, is sporadic and it's been patchy. So what we're trying to do is increase our pickup rate and actually level out the playing field so that it's the same wherever you live, that you've got the same chance of getting picked up at the right time. The diagnostic criteria for monogenic diabetes: early onset diabetes, so diagnosed at a young age, ideally before the age of 25. And we do explain this to clinicians because they think they're only looking at their young adult clinic. The oldest person we've diagnosed with neonatal diabetes was in his 60s. The idea is the person in front of you need to find out when were they diagnosed, not how old they are presenting in your clinic. And obviously we're looking for a family history, ideally in 2 members if we can, but 1 will be enough to start. Now, if they have monogenic diabetes, they're not insulin dependent. Doesn't mean the person in front of you isn't presenting as a type 1 and is on insulin. What we'll need to look at is, can we measure C-peptide? So is that person producing their own endogenous insulin? If they are, and it's post-honeymoon period of being diagnosed with type 1, so at least 3 and ideally 5 years, then you're looking at more likely a monogenic diagnosis. As I've said, it's an autosomal dominant inheritance pattern, so we're looking at diabetes in the family. Does your mum or dad have it? Do you have a child? Do you have a sibling? Do you have a grandparent? What we're also looking at, because we are seeing many more young people diagnosed with type 2 diabetes, it's not generally seen in our population who are obese, because they're often insulin resistant. So it doesn't mean to say if you're overweight that you won't have monogenic, but it's unlikely. So if we're looking in clinic, we will look for signs and symptoms of insulin resistance. So acanthosis nigricans, which can be dark staining on the back of the neck and under the armpits. And this is something we teach to clinicians. You do need to ask your patients to take the tops off in clinic. We need to be looking at areas we won't normally do. This has been part of our training, because if we can identify insulin resistance early on, then again it stops a pathway that we never need to send a patient down if we're thinking of a monogenic diagnosis. So, as we've already established from other talks, we've got 29 trusts in this East GMSA. We focused on the acute hospital trusts because that's where most of our diabetes specialists, consultants and nurses are based. Eventually we will move out into primary care because many people with type 2 are managed in primary care, but for now we're focusing on the consultants and specialist nurses that are in our acute trusts, which are 17 we're looking at. Our aims were initially establish a lead consultant and nurse in each trust in adult and paediatrics as a monogenic lead. Once we did that, and that took a lot of work initially, we then were set about advertising and encouraging them to attend the National 2J Monogenic Diabetes Training, which is run by the Royal Devon and Exeter team. The benefit of COVID was we suddenly learned how to do things via Teams and online, so we didn't have to drag everybody down to the southwest for this training, and we've continued to run this. We run this twice a year, and we encourage people to attend it if they're going to be the lead, because you need a framework to work to. 2 days doesn't make you an expert, but it does give you a framework to understand what are you considering when you're looking at a patient in front of you. Once they've attended the 2-day training events, we then try and encourage them to follow up with the masterclasses. So your 2-day will give you a framework, and then the masterclasses will look specifically at different areas. If we're looking at mitochondrial disease, if we're looking at the 1-alpha, 4-alphas, the more common ones, or if we're looking at neonatal. That will give clinicians, again, who are dealing with diabetes all the time, but this is not the diabetes they're used to seeing, that much more of an insight. And then finally, we set up a clinical network within the East GMSA for all diabetologists and nurses to attend. We run that 2 monthly, and the idea was it was a safe group in an informal environment to discuss cases, because many people have attended the training and then come along and go, I'm still not entirely clear. And that was something we recognised early on. So we've run those quite successfully. This is just a screenshot of our Future Learn space on the NHS website, and we advertise our regional meetings and obviously our monogenic diabetes course, and the next one is in the next 2 weeks. I didn't pick a very good slide, this one, to show, but basically what I was trying to demonstrate was at the start of this, so if you go back to February 22, when we started identifying the leads and getting them on board with training, we had about 46 people who have done the training. In total to date now, we're up to 96 people, and that's 96 clinicians out of 17 acute trusts, so we're doing really well with people attending the training. Attendance at our clinical network meetings has been a bit variable at times, but in fairness, the clinical pressures that teams are facing out there at the minute, I think we've done really well. We're averaging about 10 trusts. 10 trusts are represented at each of these meetings, and obviously it's 10 different trusts each time. and numbers of attendees vary, but we've had some really good case studies brought along, which then encourages discussion, and it makes clinicians go away and think about, actually, is this something we're seeing? And it's really good to get peer support, because we'll suggest, or have you looked at your ladies, your pregnant ladies with gestational diabetes? They're a good group to target, because they're quite a low-hanging fruit if we're trying to pick up a glucokinase mutation. And if you've got someone who's gone, I've tried that in my trust, it's really beneficial for other trusts, because they'll go, oh, well, if they've done it, we'll try it. So the peer support within the group has been really good. We found that quite significant. And then where we've been working towards is our pickup rate for referrals. So this last quarter, we've seen a significant increase in referrals, and I think that's reflective of the training, the attendance of the training and people's increased awareness of it. If you look at our average pickup rate, so of all the testing that we do, we're averaging a pickup rate of a positive diagnosis of about 27%. For monogenic diabetes, the national average is 27.7%, so we're doing well. And what's reassuring to see is that people have attended the training, they've understood the framework they're working to, and they're sending in the correct people for diagnosis. We're not just going, oh, every patient in clinic now has got monogenic. They're actually thinking about it, and we're getting the right people referred in. So as I say, our pickup rate is increasing. We still need to improve that, but that's where we're focusing next. So our next steps, and where we're leading to next, is to identify, we've got 2 trusts left that we hadn't identified, an adult and a paediatric lead, although I think in the data I've just seen in this last week, I think we've got all of them now. We also want to focus on the trusts that perhaps haven't attended the regional meetings. And again, as we've talked about, clinical pressures out there at the moment are quite significant. So getting people to have the time to attend these meetings is difficult. We arrange them at a lunchtime, and we try and change the day, because for some clinicians they'll go, well, Tuesdays is our clinic day, we can't get out. So we will change the days around. So that's our next focus. So we will be emailing out those trusts that haven't had representation at any of these meetings. We'll then be making a sort of concerted effort to say, what can we do to support? Can we highlight this? What are we doing? And obviously what our aim is to continue to improve the diagnosis of monogenic diabetes. Our mantra has always been to get the right diagnosis at the right time, to get the right treatment. I haven't brought case studies because time was of the essence for this session, but we've made life-changing treatment changes for people. We've had people we've taken off insulin, who've been in insulin for 30 years. And you've had 30 years of 4 injections a day, finger pricking 6 times a day. It's significant, and it's significant for the families. So we're passionate about what we do, and the clinicians we're getting on board are as well. So it's been really, really good, actually. And the East GMSA has been really supportive of our work with this. So I'd like to take this opportunity to say thank you to them as well. Lovely. Right, thank you very much. Obviously, any questions, scan the code.
Hi, I'm Gemma Chandratillake. I'm the Education and Training Lead for East Genomics. So I cover both the laboratory and the GMSA, so out working with the mainstream workforce as well. So I'm going to try and go as quick as I can. But I'm going to talk about training healthcare professionals for the genomic era and some of the systematic workforce initiatives that we've got going in the region. So, as you've heard today, there's a big focus in the Genomic Medicine Service, and rightly so, around equity of access for patients to be able to access the service, for all patients in the region to be able to, who are eligible to get the tests, to get the tests that they need, to get the counselling that they need and the support they need. So, in order to actually achieve this equity of access for patients, we need equity of access for education and training for healthcare professionals, and a sufficient workforce to deliver for all. And so you've already heard today about some of the challenges we have around, for example, laboratory workforce, but we also have challenges around getting information to people. There are lots of resources out there, but as you've heard, not everybody knows about them. So in short, we need enough people with enough knowledge about genomics throughout the healthcare system to make sure that all the patients get the service that they need. So our aim is to scope what we need to do, train, educate, and develop the genomics workforce and the mainstream workforce to deliver this and embed this in our region. So that's a big ask, because The NHS is the largest employer in Europe. It's the 5th largest employer in the world. So it's absolutely massive in terms of the number of people, in terms of clinical staff and non-clinical staff. However, there are only a couple of hundred clinical geneticists in the country and a couple of hundred genetic counsellors in the country. And so that's why we're all talking about the concept of this service being delivered by everybody else, which we call mainstreaming. So we have to get that genetics and genomics knowledge out into the other clinicians, and our specialist genetics and genomics need to be in sort of supporting those clinicians and also seeing more challenging patient cases. So this is what we're doing, mainstreaming. We've known that we need to do this for quite a while. The Genomic Medicine Service started in 2018, but even prior to that, we were already scoping around what level of preparedness was in the general workforce with respect to genetics and genomics. So we surveyed our region in 2016 widely, and we've repeated that sort of workforce survey in 2021 as well, right as the Omicron variant was emerging and nobody wanted to fill in any questionnaires about anything. But we did. And then we've also been, so I'll talk a little bit about what came out of those surveys, but I'll also talk about some of the systematic interventions that we've been making in the East. You've heard a lot today about very specific work streams. So Lynch syndrome, sudden cardiac death, NICU, PICU, familial hypercholesteraemia. But it's important to note that the Genomic Medicine Service is much broader than that. It touches on all aspects of medicine. So we know that when we focus on a work stream, we can kind of get it going. But we have to be thinking more broadly about that, about the service as a whole. So that's what we've been trying to do. So back in 2016, we did the survey, and we were trying to look at healthcare professionals, doctors, nurses, pharmacists, what their awareness of genetics was, whether they'd had any training, whether they cared, whether they thought it was relevant in any way. And we really also wanted to identify our ability to communicate with them, because we knew we would have to be able to communicate at scale, in all the different trusts and all the different healthcare systems that are in our region. So we were able to get about over 1,000 responses from diverse professions and clinical specialisms all over the geography at different stages of careers. And from that, we found, if we looked at our doctors and our healthcare scientists, we found that quite a lot of them, maybe 2/3, had actually received some genetics training in their formal education, so in their undergraduate degrees, but nothing since then. But about 1/3 of people claim that they've never received any genetics training whatsoever, ever, or at least they couldn't remember it. However, when we looked at nurses and midwives and pharmacists and allied health professionals, the situation was quite different. And these groups of healthcare professionals claimed that they'd had no genetics training whatsoever at any point in time ever at all. So, I think that's probably one of the reasons why there's been a big sort of push in the nursing profession that you've just heard. So people, they had a lack of awareness about genetics, and there really was a real perception of it, that it's not relevant to me. I don't know what it involves. I'm not sure I'm not aware of this field. I don't know enough about it. I don't know what it even means. My role doesn't involve that. However, some people had kind of understood that it was coming, or that they'd heard stuff about genetics and genomics, and they felt that it was coming, but they felt they didn't know about it. So, for example, a neonatologist would know that there had been significant advances, but they didn't know that they could bring it into their clinical practice. We don't know which patient should be referred. I'm getting involved in these meetings, but they're all talking in acronyms, and I don't know what they're talking about. So some professionals had a general awareness of what was coming. So that was our 2016 survey. If we go to our sort of 2021 survey, again, even though this was hitting during Omicron wave in 2021, we still got about 750 responses. And if we were asking people, have you ordered any genetic or genomic tests in the last 12 months? Or have you referred any patients to clinical genetics or for genetic counselling in the last 12 months? We got about 1/3 of that group of individuals saying yes and 2/3 saying no. Now, That's probably an overrepresentation of people saying yes, because we're able to reach people. So these are people who presumably we've engaged with in some way. But you can just see that still in 2021, we know we've got a long way to go. If we ask, how confident do you feel in assessing whether or not your patient is eligible for testing? You can see here in the sort of the red colours is where people feel confident. So about a third of people feeling confident, about 2/3 of people feeling not confident or thinking it's not relevant. Do you need more training? Here, about half of people saying yes, and again, a bunch of people thinking it's not applicable. So, 3/4 of people needing some training. Still in 2021. So this is just to outline what the challenge is in front of us when we come to actually mainstreaming. There's a real lack of awareness. There has historically been a lack of training. I would say there are a lot of training resources there now, but there's a lack of awareness of those training resources, and there's a perceived irrelevance to the roles. So we concluded at this point we need more training opportunities, we need a strong communication strategy, which I think we really have started to build in the East, and we need some systematic interventions. So I'm just going to talk a little bit. We've talked about nursing and midwifery and pharmacy, and I don't think we've talked that much about doctors, medical training. So we'll talk about that now. If we look at medical training and how doctors receive their training, they will go to medical school, then they will be foundation doctors, then they will train along a specialty training program, and then eventually they will take up a post as a consultant. So we have to look at this pathway and think, where can we put a systematic intervention in to hit all doctors? Because we know that they don't know about genetics. So we've been working at the foundation level, we've been looking at working in the training programs, so working with the deaneries, and then we've also been looking at establishing communities of practice as well, with those clinicians who are already established clinicians in more sort of senior posts. So the advantage of working with the foundation level doctors is this is a post-medical school, pre-specialist training intervention point. So we can get all specialists, people who will go on to be all flavors of doctor in one go, including primary care. And we can do this at a sort of regional level, so we can sort of work across the region. So since 2018, we have been running half-day genomics events with the deanery, several per year, and these generally get pretty good feedback and are pretty generally well attended. And we've noticed a sort of uptick in people's awareness of genomics over that period, but we're still delivering this sort of intervention because doctors come in from all different backgrounds, and so there's a lot of variability, and we can catch them at this point. We've also been working, looking at the regional training programs. So I think we've got 2 deaneries in our region, in the East Midlands and the East of England. If we look at the East of England, there are 63 training program directors. So these are the people who deliver cardiology training, neurology training, endocrinology training. So we thought, well, let's talk to them about their awareness of genomics and whether they've incorporated it into their training program at all. And the take-home message here is that thin, pale blue sliver where we're asking, have you incorporated genomics into your training program? The thin blue sliver is the yes. The orangey reddy ones are where maybe a bit, or I know I should be doing it. I should have done so. And then the dark blue is where, it's not relevant to me. And I've had this from OBGYN. I've had this from all different areas of medicine where it really is relevant. And then a whole bunch of people who don't return the survey, even if you ask them lots and lots of times. So, this is the first challenge, is one of engagement of the trainers, the people who are delivering the training. Of the 38 people that responded, training program directors that responded, 14 of them thought that genomics is not relevant to their specialty. Now that's just not true, but that's the state of affairs. So we've got work to do right there with our trainers. And also, just like everybody else, they're pushed and they're pressed, and it's just not their highest priority. So we've got to make these cases then. So we are working with the deaneries in the East Midlands and the East of England to try and support the incorporation of genomics into these training programs. And both of the deaneries now have embedded genomics fellows. So we're sort of pushing them to sort out their training and trying to provide support to them to do so, and signpost a lot with respect to resources. But there's still quite a long way to go. I'll touch on communities of practice. You've just heard a really nice example of a community of practice for monogenic diabetes. So a community of practice are groups of people who share a concern or a passion for something that they do, and they learn how to do it better, and they're interacting regularly. So it's kind of like your peer support group for learning, if you like. So we thought, how can we, where's the biggest impact we can make in terms of getting genomic testing or patients appropriately assessed? And if we look at rare disease, rare conditions, we know that 80% of those conditions affect children. So let's go to pediatrics. Let's just work with pediatricians, because we've got pediatricians in acute trust, and we've got community pediatricians, and we've got them all over the region. So this would be a good equity of access intervention. So we've been running the East Pediatric Genomics Forum for 2 years now, meeting monthly. We have this monthly meeting, and we also have an online, we record it, and we have an online platform where we store resources and slides and the recordings of all of those meetings. So if you can't make it, you can still get the information. We now have almost 600 pediatricians from the region on our mailing list. So we have gone and done the work to find all the pediatricians in all the trusts in the region, and we have a mailing list so we can reach people. And this means that we can tell them about any particular thing that's relevant to pediatrics that we want to. So monogenic diabetes or familial hypercholesterolemia, as these developments come through, we can take them to that large group. We have a lot of those healthcare professionals are engaging with the platform, so nearly 400 of them are actually on the platform, and some of the recordings of the sessions have been viewed more than 100 times. So we think that having a platform, having a regular touch point with attendance by the laboratory and with attendance by our clinical genetics colleagues, that this is a scalable model for those with the genomic expertise to support a large number of mainstream clinicians to implement genomics into their practice. So just want to say a big shout out to Nottingham Clinical Genetics team, who religiously support this forum every month, and to the lab as well. It's really important that you're there. We're doing other things as well that we can do at scale. So things like e-learning, we can create e-learning resources that then it's just a communications exercise to push that out. We can do it once, and we can push it out, and we can monitor uptake across the region. So this has been quite successful for us for training clinicians in how to take consent or how to have consent conversations with patients around whole genome sequencing. So rather than me training every single clinician in the region, we can put an e-learning package together, and then we can point them to that. And we can also monitor the uptake as well. So we've got some e-learning for hereditary breast cancer, for inherited cardiac conditions, and genetic testing in primary care that is live, and we just need to do some push out. And then we're also working on an e-learning for fetal medicine as well. So I'm Gemma Chandratillake. Feel free to email me if you've got any questions. This is only a snapshot of some of the stuff that's been going on, and just sort of trying to illustrate the scale of of the mountain we're trying to climb, and some of the ways that we're thinking about doing it. Right, thanks.
Thank you very much indeed for making it to this stage. Of course, I want to thank all the speakers up to this point now, but we've now got an opportunity to actually engage not just with the speakers, but everybody who's been attending this showcase. So this is, in a sense, almost the highlight of the afternoon. What I would like to kick off with, because in a sense the Q&A is definitely about the talks, but it's also about the people we've got on the stage, but also everybody in the audience and everybody's ability to interact together. The questions for the panel were sort of framed around opportunities and challenges, and I just want to pick that one up very briefly for a couple of minutes. We've got some very, very distinguished guests on the stage, and I'll ask them to introduce themselves as they speak, if that's okay. But what I would like to do is to follow that theme of opportunities and challenges, and firstly to ask Alistair Kent if he could perhaps reflect on opportunities and challenges in genomics, maybe from the rare disease perspective.
Thank you.
Ah.
Right, thank you very much. Thanks. I'm Alistair Kent. I was the Director of Genetic Alliance UK for just over a quarter of a century, but I've retired from that role. I am actually the chair of the Rare Disease Advisory Group for NHS England and of the UK Rare Disease Stakeholder Forum, but I'm not officially part of the NHS, so anything I say can just be put down to the meanderings of a grumpy old man here. But thinking about the opportunities and the challenges, I mean, one of the things that has struck me listening to the talks today is just how fast things are moving. You know, when I started my engagement with genetic issues as a patient advocate 30-odd years ago, genetics was a rather obscure corner of the National Health Service that paediatricians sent the patients they didn't know what to do with to. But now it is transforming the approach that we have to disease and creating opportunities for patients, for families, to understand what's happening and to take control of their lives by engaging with the condition that affects them or their child, and rather than being driven by it, taking that control and trying to drive change. The challenge that we face is how to seize that opportunity, how to translate it into services that span the whole of the health service, from conception to post-mortem, from John O'Groats to Land's End, such that wherever you are, whatever your condition, you have equity between conditions, equity geographically, equity of opportunity to access those interventions which will alter the trajectory of your condition or your child's condition for the better, so that any family living with a condition which is genetically derived can expect speedy access to user-friendly, appropriate, timely services which will deliver state-of-the-art scientific knowledge equitably, promptly, and sustainably.
Thank you very much. Can I put the same question to you, Mike, if you introduce yourself? There's a microphone hovering. The opportunities and challenges of genomics with respect to cancer.
Okay, thanks, Dick. Hi, everybody. I'm Mike Ryan. I'm head of service for the East Midlands Cancer Alliance, and we cover the entire East Midlands, which is about a circa 5 million population. The NHS infrastructure is roughly 5 integrated care systems with an accompanying 8 acute trusts as part of that. Just shy of 100 primary care networks, and underneath that about 500 GP practices. So quite a few players in just the NHS market in that respect. I think genomics presents both opportunity and risk, and there are good points and pro points depending upon how you look at it. For me, cancer is very personal to all of us. So personalised care and the uniqueness of us individuals to receive access and treatment for cancer is critical. Although that goes without saying, it's more along the lines of how we create an infrastructure that will accept and in mainstreaming the genetics testing and actually the genomic services that exist. We invest funding into different areas, and I think we invest something around 30% into early diagnosis, which encompasses a little bit around early detection as well. The opportunities specifically are forecasting in about 10 years' time. How we look at cancer will be very, very different. How we approach cancer will be very, very different from an asymptomatic point of view, rather than just treating patients based on presenting with symptoms. I think the larger challenges we have overall has been referred to throughout the course of the day. and again, it kind of goes without saying, but I'll say it anyway, is the capacity to deliver what's coming. We're already facing quite a fragile, limited resilience on the back of COVID and recovery. Clinicians, teams, non-clinicians are working overdrive to catch up. So they're doing more faster, and it's still not quite breaking the back of what we need to get to overall. There's billions being invested in terms of diagnostics as a whole, but again, coordinating and making all that work for the same shared goal is particularly tricky when we put in context the infrastructure just the East Midlands alone has, much less the entire east of England, East Midlands, and the greater, broader country.
Thank you very much. Can I ask you just to pass the microphone to Eddie Blair, who's going to answer the same question from the...
Thanks, Dick. I think we call this a hospital pass, don't we? Yeah. So you've heard from me as an individual, but now I'm up here as Vice Chair of the Patient and Public Voice Panel of East Genomics. And I guess the challenges and the opportunities are, I've heard lots and lots of exciting things happening, and I've heard lots of mention, even starting out with Sue Hill, right to the last talks, about patients and informing patients and educating patients. And I think that is a huge challenge, because you've got a range of people who are desperate to know and know every detail, and distilling detail into something meaningful for patients is an important thing. But then there's others who just want to put their heads in the sand and not know any more about their condition. And it's important they do know about the condition, because as Alistair says, the time has come for people to actually grasp their situation and make the most of it. So rather than putting their head down in the sand and getting depressed, part of illness is the mentality as well as the physicality. And I think as a patient public voice, we should be, again, go back to what Alistair said, translating the information that they're coming out with, that Genomics East is coming out with, and translating that into something meaningful that becomes not just actionable for healthcare professionals, but responsive for patients and their partners and the wider public, and for them to understand what's going on. So I heard lots of things today where the PPV would love to get involved, and I'm thinking already of some of the ways that the PPV can evolve from just being a sounding board to a better communication board as well. So I think that's one of the opportunities for the PPV, as well as the challenges, is fielding all these things and making something happen. I'm very keen that we make something happen.
Thank you very much indeed. I've got a big list of questions that people have already submitted, but do we have a roving mic? We do. Are there any particular comments from the floor in response to those few opening comments? If not, don't worry, I've got a lot of questions that I'm going to ask the panel. Joe.
Hi, it was just an acknowledgement and thank you really to the PPV panel so far. So I know certainly the projects that I'm involved in, you've been invaluable in providing that feedback. So I would very much advocate that if anybody else is interested in getting in touch. There's a wide variety of expertise and knowledge within that group.
Lovely, thank you very much. I'm going to start selecting some of the questions. Some of these questions I've sort of tried to merge together. Gemma, where's Gemma? Gemma, you are up first. So a couple of questions to stitch together. Really, what is, in terms of the uptake of genomics in the UK, how does that compare to other countries, and what can we learn? And in the same sort of vein, what is good that other countries are doing that we're not doing?
Yeah, so I think this question is coming to me. So I have a background. I trained as a genetic counselor in the United States, actually, and I also worked in a genomic startup out there. So I was kind of on the wave of genomic implementation out in the US. I would say that there's real opportunity for the UK as compared to other countries, because we do have a National Health Service. That's what actually makes us unique, and that's what's been acknowledged by the government and the NHS leadership, is that having a National Health Service puts us in a unique position, because you'll probably have gathered from the talks today that being able to look at data at scale and implement things in a systematic way is really valuable. It's really valuable in terms of driving things like clinical trials to come to the country, because people, pharmaceutical companies can come to a healthcare system where lots of people have had genomic testing and were able to kind of do things at systems level. So I think that opportunity has been really grasped by the government, and that's what's different. So, for example, in the States, you will have particular hospitals, very academic hospitals, doing amazing genomics implementation practices, but they will be for a small population of people. They don't have, one of the largest integrated healthcare systems in the United States is about 4 million people who are really pushing genomics. That's Gajweska system. So they're big, and they've been really pushing on genomics, and they've got 4 million people. In England, we've got 55 million people. So we have a power of scale that the US doesn't have. So that's the opportunity. However, that it comes with the fact that we don't really have a National Health Service. We have lots and lots of different hospitals, all on different systems, lots of them on paper, and it's not actually very easy to join it up. So we maybe aren't the first on the curve. Maybe some of those big projects first start out in the US, but we have the ability to really implement this at scale in a way that they don't. I think that's the biggest difference.
No, thank you very much indeed. I don't know if anybody on the panel has got experience with other healthcare systems that they wish to. Mike.
I think I'd just add, thanks Gemma, I'm from the States as well originally, although I'm official and Anglophile and adopted as a British person after 15, 20 years. I think what she just highlighted is not just spot on, but also the NHS is in a unique position further because of the angle on reducing health inequalities and focusing on equity of access, which is through and through how we operate in everything we develop, how we implement, but also how we evaluate for continuous improvement. And I think the final thing I'd say is we listen, we learn, we've got a strong reach from a global community based on the industry experts even on the stage today. So there's one or two people I know who are going to different conferences, left, right and center, presenting papers and publishing. So we have access to the international educational research and input too. So we're strong at listening and learning quickly.
Okay, thank you very much indeed. I'm going to move on. Thank you for those answers. I'm going to move on to the next question. This is directed to the whole panel, but I'm going to nominate Julian to tackle this one first. It's like a Viva, isn't it? This is very much around what does the panel think about sort of in the sort of a 5-year time frame that patients are going to have access to their genomes, and that access is going to allow them to present genomic information to clinicians, to prescribers, for example, to improve their healthcare. So it's you mentioned the Lynch app a while ago, which seems to me to be the current incarnation of where that might sit, having access to your genome.
I think there's a couple of areas. So the first one is pragmatic, practical digital applications, is that you've got to enable people to use big data at pace, at scale, in a pharmacy or at their general practice in a simple way. So we know, for instance, that your DNA code is still only as powerful as your postcode, and wouldn't it be amazing if we could link those together, as well as your sleep app, your Fitbit, and your clinical data. So we need not just a logistic skills to be able to integrate that in the way that Gemma said. We've also got to have a debate as to whether we want our alcohol intake, which is factored into the modelling, to come from what we say or from our Tesco club card. Other club cards are available. So we need that debate as to what information we're bringing together, because this is not going to be about what could be done. It's going to be about what should be done, because the technology to integrate that sort of thing in the high street for people to get better prescriptions or better way of working out their screening, I'm sure will be available in 5 years. There's a lot of red tape around that. The second aspect is about hearts and minds, and we've got to take not just patients but other clinicians with us. As was said earlier, there aren't very many clinical geneticists or genetic counsellors, and if we're moving from rare diseases into real applications for A&E on a Friday night and general practice on a Monday morning, to take that bold step into personalised medicine and beyond, we're going to need to have a lot more champions on board who are literate, who are engaged, who are inspired. And what does it come down to? Showing improved patient outcomes. If you can show that it will be better for their patients so that they tip over into, gosh, why aren't I doing this? And then you enable them to do so, we have a really good sporting chance. The capacity to change things in the next 5 years is definitely there. And I can certainly see there is beginning of political will and technological advancement. I think it's partly down to whether we can bring our colleagues with us.
Thank you very much. Eddie?
Just to link back to people's experience in the US as well, I remember there's a thing called GINA in the US, the Genetic Information Non-Disclosure Act, and that was developed to stop insurance companies, because healthcare is very different in the US to the way it's practiced here. It was to stop insurance companies using genetic information and the potential for someone to get ill to actually change their insurance premiums or even not insure them. And I think that leads into thinking that as people get access to their own data and potentially share it indiscriminately, because youngsters in particular are willing to share almost anything on Facebook or Twitter or what's that funny app that kids use? Your kids use it, don't they? No idea. TikTok, yeah, TikTok or whatever that other thing is. You know, sharing of that information is one thing, but the flip side of information is there's people out there creating misinformation and worse, creating disinformation. And I think we need to be guarded about how some of the things that we want to do as scientists and clinicians and leaders in the field want to do to stop that disinformation, stopping people becoming willing to embrace what we're trying to do. So I think that's a challenge actually, Dick.
Okay. No, thank you very much indeed. Yes, please pass the microphone to Sarah.
I'm going to make two brief comments. Firstly, I think it has to be trusted. However we do this, it has to be trusted by our colleagues, because there are far too many people that go in with spurious results from gene testing companies and ask their GP to refer them for breast screening or for anything, and I can just imagine that is an impossible situation for anyone to be in if they don't trust the data that they're being presented with, and that noise will just get overlaid on anything until we actually sort out what the NHS is willing to provide. And then the second thing, really just thinking about this, if I had my own genomic data, the first thing I would want to know is what is my highest, most penetrant risk. I don't care about whether I've got a polygenic risk score of 1.01 for something. I want to know, is there something I should be doing today that will really make an impact on my health span and my lifespan? And I think if we are looking at people's genomic data, we should ensure that we're looking at it the whole thing and not just picking out individual risk scores for things. We have to look at the most impactful things first, because otherwise we could spend, and people can spend half their lifetime fiddling around at the edges and actually then end up, having a completely treatable disease that they just were not aware of. So I think it's the sequence of events that needs to be correct, as well as the trusted output of that genome that needs to be understood in the healthcare context that we work in.
Thank you very much. Alistair.
Yeah. I mean, Niels Bohr said prediction is difficult, especially when it's about the future. But I think one of the things we've seen today is that the opportunity to advance access to an accurate and timely diagnosis is accelerating through loads of the things which have been talked about during the course of the day. But the thing that I think we need to focus on now is how can that diagnosis change what happens post-diagnosis? You know, how can we develop downstream modifications to what the NHS does as a result of giving a patient, giving a family a diagnosis, so that, you know, we invest in new ways of delivering services. I mean, in some cases we might go from, you know, organ-based organisation of services to molecular system-based organisation of service. Whatever, we need to build into the health service the opportunity to be flexible and timely in its incorporation of new opportunities to change patient benefit, to deliver health gain. And also we need to look at the gap between the opportunity to diagnose and the opportunity to treat. I mean, there are something like 7,000 or 8,000 rare diseases that have been identified, but only about 5% of them have a disease-modifying intervention of any kind. Yes. So how can we close that gap? Where can we invest our research expertise, our engagement with the pharmaceutical, the biotechnology industry, our commissioning strategies to try and close that gap between diagnose and modify the condition?
Thank you very much indeed. I'm going to move the conversation on a little bit, if that's okay, and pick up a question that I'm going to put to Vicki and Vicki, if that's all right. I'm going to go Vicki K first. And again, paraphrasing this one, we put a lot of effort and a lot of thought into this sort of the consenting, the pre-testing part of the pathway at the moment. What about once somebody receives their result? What do we need to do to put the right support and counselling in place when somebody has received a result, especially as there's a significant move into what we've already heard described as mainstreaming?
I think it's very important that we make sure that post-diagnosis, post-genetic diagnosis, that they're fed into the genetic services so that they get that post-genetic testing care. For patients that have had testing in the mainstream, they may have had a limited amount of pre-test counselling, so that they will most likely need a lot of support afterwards in terms of looking at the implications for different organs within themselves, but also for different members of their family. An example being for patients that have had mainstream BRCA testing, predominantly they will have been advised about the implications for their breast cancer treatment, but because they're being treated for breast cancer, quite rightly, their clinicians are only thinking about that. They won't necessarily have thought about the ovarian risk, they won't have thought about the implications for their children potentially, and the psychological implications of future risk. So it's really important that we make sure that all the mainstreaming services are linked up to genetics. At the moment, there is a bit of a gap there. The GU is very aware of this gap and the fact that we're pushing out genetic testing to other services and specialties, but we haven't really thought about who's going to coordinate the screening and the care after they've had testing from a medical or a psychological point of view. I'll let the other Vicki.
Thank you. I was just going to add that from the cystic renal disease pathway that we explored, we know that nurses aren't involved in that at any stage of the diagnostic testing, only later on. For the NICU-PQ project that we're running, nurses are involved in the consent and sampling rather than the return of results part, and so there is part of the pathway is managed by the clinicians, and then presumably
clinical genetics. So there is, but in other pathways, we know that where patients, in much more established patient pathways such as breast cancer, nurses do have a much stronger role that goes beyond the return of results and supporting patients through treatment. So there probably are learning points for us there. And I was just going to ask Anita actually about the genetic diabetic nursing role and how you support patients between, after the return of results, because I know that you're involved there.
Yeah, we were established, obviously about our role was 18 years ago. We've had genetic diabetes nurses, so we all had to undertake genomic counselling modules, but for our patients, and again that's not enough, but for our patients they're often established with diabetes, so you're dealing with a known already and we're making treatment changes. The implications of the family were the areas that we weren't used to and we had to learn, and we follow up families, but now that it's become part of embedded in each trust, that's an issue that needs looking at, because inpatient nurses are not used to following up people outside of acute trusts, and that's an area we do need to focus on next.
Yeah, so I think what you've identified is clearly pockets of very excellent practice, but in that post-test environment within the broader NHS, it's very much identifying the need and capacity building to get it to the right place at the right time, isn't it? Brilliant, thank you. Kate? This is a nice focused one, this one.
Oh, good.
But a spin-off question. So with the introduction of saliva testing for FH, can that be delivered via community pharmacies, for example? You've given that hub model, and I'll extend that question a little bit. That sounds like a very pragmatic, sensible approach for families to have samples taken for genomic testing. Is it more widely feasible?
It definitely is more widely feasible, and I think we're using this opportunity to, within the FH pathway to drive a change in technology that we're using, but it's applicable to lots of other testing methods, testing of other diseases that we're hoping to mainstream. Saliva, we've been using saliva DNA for a while to do cascade testing, to do predictive testing for breast cancer patients or young patients that are scared of needles, or patients where we just weren't able to bleed them. So this has been happening for a while to do cascade testing, but of course with COVID that became a big problem. Saliva coming into a lab and our lab teams dealing with saliva was really, beginning with COVID, we get a bit of a flashback about it. And our lab teams are really struggling with thinking about how they deal with blood, let alone a saliva sample coming into the lab. So we really shut down some of those systems. And so this is an attempt also with this project to do some work with our lab teams to make sure that they're comfortable in extracting saliva again. And the feedback's great. I just spoke before. The feedback from the team has been great. They're really happy to start doing this again within the laboratory. So this is a source of DNA that can be used really widely. There's some technologies that we can't use saliva testing for, but for the majority of the testing that we are doing within the laboratories that's targeted, where we're pulling down different bits of DNA, we can use saliva. So there's huge opportunities, I think, for pharmacogenomics, for cascade testing, for lots of diseases moving forward.
Lovely. Thank you very much indeed. And sticking with the pharmacy theme, have we got Paul Selby? Ah, wonderful. So this question for you. So this says, what can I do after this showcase today to increase awareness of genomics in my role as a primary care pharmacist based in general practice?
So probably the one thing that we've always said as a sort of takeaway is genomics helps us to understand the variation we see in the way that people react to drugs. So if you take away one thing, it's that there is genetic variation, and that can help us explain that. And so that's why it's so important that we start to bring these in. In terms of, I think was the question, the one thing to take away is probably to start to educate yourself and your colleagues on the opportunities that genomics has for your patients, whether that's clinics that you run, or whether you're looking at medicines optimization and therefore maybe pharmacogenomics. It's about really finding where genomics impacts your care and not trying to do it in another way, I think.
Thank you. And can I suggest they, in particular, get in touch with you via our website in terms thinking about signposting? We've spoken an awful lot about genomics education all the way through training and into professional organisations, and a lot of it is sometimes signposting, knowing what's around the corner, knowing how to prepare. We'll do it anyway.
Yeah, but welcome any emails, comments, etc.
Wonderful, thank you very much. And an intriguing question here, which I'm going to give to Sarah again. Sorry. Just thinking forward, where do you think East Genomics is going to be in 5 years? Just pick one thing. Or let me rephrase the question. Where do you see East Genomics to be in their journey in 5 years?
I'm the medical director of East Genomics Laboratory Hub, just to give the background, but I'm a clinical geneticist. I think just the people in this room that have given excellent talks today makes me really excited about the opportunities that we've still got for the next 5 years. People like Kate, Patrick, who work in the lab and actually work to deliver the National Genomic Test Directory, means that we have an amazing opportunity to continue to deliver that at the highest specification. So if we were to be really positive about it, we would grow the workforce and we would grow the clinical scientist workforce so that we had enough people to actually analyse and report. Currently, we've been given lots of NHSE funding to increase the number of the technology and the automation in the laboratory, and we've got a head of technology sitting down there who's done an amazing job at installing new machines in a much smaller lab than we need to have. So probably in 3 years' time, we'll have moved from our current premises to a much larger space to allow the automation and the new technology to be in place. But that still leaves a massive gap between the number of the amount of data generated and the interpretation and analysis of that data at the most important level and returning those results back to the clinicians. So I think Gemma's given a great overview of how much work still needs to go into workforce development for the NHS. So 5 years' time, a bigger workforce, I really hope, a larger lab, still an amazing workforce within that lab, but greater number of technologists, greater number of biomedical scientists and clinical scientists trained to interpret. And just exploration of the test directory by all specialists, with more implementation in those areas that have been shown to have the greatest benefit to patients, either because the patients are vociferous or because we've proven it through health economics, or both, hopefully.
Lovely, perfect. Thank you very much indeed. That actually also answers another question, which is about how do we meet demand and capacity. So I think you've answered that.
I don't think I mean, that was the Elysian view of it. Okay? I think there's a lot. There's a massive gap,
yes.
And I mean, Kate, Gemma, Patrick can talk to that.
Yeah, technology, automation, workforce. Eddie?
I just wanted to follow up your question to Kate and to Patrick, because Patrick showed a very striking slide about turnaround times, and there was that big gap, I think, between patients consenting and DNA being received and stuff like that. Is that something that can be solved in the next 5 years as well? Because you know where the issue is, right? And it can be Patrick or...
Yeah, I guess one of the advantages of us really looking closely at the data is to have transparency, so it's really clear where those gaps are and where those efficiencies can be acquired. And I think amidst that somewhat complicated graph with all that variability in green, suggesting that there's, you know, some patients taking a long time. There was little vignettes of patients that took a very, very short amount of time. So what we need to do is explore that there may be valid clinical reasons why it takes longer. It might just not be that ineptitude or, you know, an imperfection in the pathway. There might be valid clinical reasons. So we need to tease that out in more detail. But I think inevitably there's definitely opportunity to improve. But I think visibility to where those areas are, I think, is the impetus for our clinicians and colleagues and everybody involved in the pipeline to be able to embark on those improvements.
Yeah, I agree with Patrick. I mean, I think one of our big challenges is ensuring that our clinicians know that a sample's reached the lab and been sent off for testing. And that's one of the questions that we often, and phone, you know, the phone call comes in. Did you receive a sample for this person? We sent it, you know, 3 months ago and we haven't got a result. And then we dig around and figure out that actually that sample never arrived. And so this is a huge challenge. We get asked by clinicians, well, Amazon can do it, so why can't you? But and I think that is one of our big challenges over the next 5 years, is in ensuring that we have the slick pipelines and we put the pathways in place to mean that those sampling issues are not an issue. I mean, we know it works well. Maz gave us a great talk about R14. We've heard about R21. So when all the things slot into place and a pathway is carefully controlled, then turnaround times can be really fast. But we need to implement some of those things in a much easier way across our system.
Julian, you wanted to make a comment?
In 5 years, any patient undergoing a genomic test should have a digital self-navigation guide that will support their decision-making in a healthcare capacity moving forward. So be it in a pharmacogenetic, or if they're identified at being a risk of disease or a targeted treatment already for instance, their tumour. So there should be a way to simplify that to help them and their clinician through that decision tree, and that should definitely be possible.
Okay, thank you very much indeed. I think we've just about come to 4 o'clock, or maybe a few seconds afterwards. I apologise if we haven't got to your question. We will aim to get some answers to you, or some answers onto our website. There was one particular question about the role of artificial intelligence. Sue Hill mentioned that briefly. The NHS England are establishing a genomics network of excellence covering artificial intelligence, so it's clearly top of everybody's agenda. So just to put that final point in. And as I said, we'll get to the few questions that we've not been able to answer today. But as we're at 4 o'clock, I just wanted to say an enormous thank you to our speakers, to our panelists, and above all, everybody for attending today. This has been our first showcase event. I personally feel it's been a fantastic whirlwind of a day. I've not stopped thinking about everything that's happened, and we will, of course, with your permission, hope to stay in contact about this event and about the co-development of future events going forward. I also wanted to say a very, very big thank you to the team behind this event, which is, let me make sure I remember all the names. So we've got Ian, Laura, Marie, Pauline, Lucy, and Elizabeth. So I think for all of those people, a huge round of applause would be very grateful. So, Emmanuel, do you have any closing remarks, or not at all? Thank you very much indeed once again. Thank you.